usually affected first. Loss of vibration perception and proprioception, deep-seated gnawing and aching pains, muscle wasting can be seen in the later stages, and abnormality readily detected by EMG. So, simplified view of this peripheral nervous system or a parasympathetic nervous system is motor, sensory, and autonomic. I am sure all of you are aware about this. The myelinated large fibers which deal with the touch, vibration, position sense, and this is what I was talking about, the sensory A delta or C unmyelinated. Similarly, in the autonomic, the C fibers or the unmyelinated fibers are the important ones which we should look at. So the autonomic neuropathy, what I was trying to imply, this is results because of changes in the texture and turgor of skin. This results in changes in the texture and turgor of the skin, which results in dryness and fissuring. A lot of us, we see in clinical examination, the feet are fissured, they're very, very dry, literally looks like whitish powder, and we neglect. And that's one of the easiest ones. And routine examination, we can pick up that this patient might have autonomic neuropathy, and this dryness predominantly affects the plantar foot, which I just described, and dysregulation of the local perspiration may also contribute to increased moisture and this increased risk of fungal infections, which we see in the feet and the toes. So what are the symptoms? The positive and negative symptoms, that is what sensory symptoms have been bifurcated. What are the positive symptoms? That is due to the excess activity of the nervous system, the spontaneous pains, the allodynia, hyperalgesia, dysesthesia, or paresthesia. The negative symptoms due to the defect in the functions, hypoesthesia, anesthesia, hypoalgesia, or analgesia. End of the day, these sensory abnormalities and pain paradoxically coexist, and each patient may have a combination of these symptoms. So it's very, very important for us to spend little time and to elaborate and interrogate the patient properly to get these positive and negative symptoms so that we can go ahead and treat them in the future. And this is the definition. I'm sure for this August gathering, we need not describe or define these definitions, but allodynia is something which is a pain due to stimulus that does not normally evoke a pain. That means a simple touch, the patient will sense a very high degree of pain, or cold, extreme heat can give rise to a burning pain, which is not usually seen because of the same stimulus. So that is something which you should, because the clothing itself can be very uncomfortable for many of the patients. So all the other definitions, I'm sure all of you are aware of: hypoesthesia, anesthesia, hypoalgesia, all that. So the diabetic peripheral neuropathy, numbness or insensitivity to pain or temperature, very important. Tingling, burning, pricking sensation, sharp pains or cramps also are described. Extreme sensitivity to touch, even light touch. That's what I said, allodynia. And loss of balance, coordination while walking, muscle weakness, loss of reflexes on examination, and symptoms are often worse at night. And this is what we should ask for. So whenever a patient comes with this, you should definitely spend some time in taking a pain history that is about duration, frequency, quality of the pain, and intensity of the pain. So just be alert. Common verbal descriptions of neuropathy, which can be local language, like electric shock-like sensation, is very typically described in Karnataka or in Bangalore. That is something which is shock-like sensation, which is typically described for diabetic feet, which you should be aware about. So the shooting, burning, tingling, numbness, these are all the various electric shock-like sensations which patients may describe in their local slang. So the signs and symptoms, to summarize: the diminished vibratory perception, feet and legs often affect first, food problems such as ulcers, infections are very common, frequent worsening of signs and symptoms at night, loss of balance and coordination, muscle weakness, numbness, reducing the protection sensations like pressure, heat, or cold, sharp pains, tingling, burning, unusual sensitivity or tenderness when feet are touched. That's allodynia. We should remember even footwear, they can feel very, very uncomfortable. So this summarizes the neuroischemic or the neuropathic ulceration, gangrene, infection, and end of the day, the amputation. So this is the cascade of events which goes across, whether it can be ischemic or due to neuropathy, that is nervous system. So this is typically the classification of the neuropathy: the large fiber, small fiber, proximal motor, acute mononeuropathies, or entrapment syndrome. This is a typical PG question, what we ask: the types and what is the sensation, the pain, tendon reflexes, and the motor deficits associated with this. I'm sure you can visualize in the slide. Now, the most important, we need to identify who are the patients at risk: advanced age, people who are alcoholics, cigarette smoking, long-standing diabetes itself, hyperglycemia or fluctuating sugars, hyperlipidemia, hypertension, increased height, also point to be noted, kidney disease, males are more and overweight people are at more risk to develop this neuropathy. So how do you approach the diagnosis and management? Always suspect the DPN based on the history and clinical examination. I again emphasize it's a history and clinical examination which gives us a clue to diagnose and treat. So confirm neuropathy using the objective test, exclude the non-diabetic causes, explain the diagnosis to the patient, advise the lifestyle measures, check and optimize glycemic control. Very, very important point. We neglect the root cause, that is the glycemia, and then try to treat with all kinds of drugs. So remember, Cochrane study database has shown in 2012 itself that 60% of the symptoms of neuropathy can be controlled with good glycemic or tight glycemic control, both in type 1 and type 2 diabetic. DCCT trial have clearly showed in type 1 diabetes up to 60% of the symptoms can be eluded with just tight control of diabetes alone. And of course, later review the patient comorbidities, treat the patient as a whole, and add appropriate pharmacological therapy after excluding all this. So what are the tests? Autonomic tests, electromyography, monofilament testing, nerve conduction, quantitative sensory testing. These are all the various ones. I'm sure all of you are aware about the vibration, monofilament, and nerve conduction velocities. So the nylon filament test, which is very common, bedside, very easy, 1 minute you can do this. And the nerve conduction study and the EMG test helps to assess how well the muscles contract to the signals from the nerves. And this is something which can be advised on an outpatient basis as well. And electromyography, skin biopsy, quantitative pseudomotor axon reflex testing, which is Cuisart, recall. And this is something can be told in particular set of patients. Now, very important slide which talks about autonomic symptoms. It can be orthostatic, genitourinary, genitointestinal, pseudomotor. Very, very important point to note because we tend to miss these autonomic symptoms very commonly in our routine practice. Dizziness, lightheadedness, very commonly neglected, especially in the elderly, fatigue, and nausea, palpitations, what we call coat hanger headaches. Genitourinary can be bladder urgency, frequency, incontinence, nocturia, erectile dysfunction, ejaculatory disturbance. I'm sure Dr. Jumani is around and Dr. Shashank Joshi sir is also talking about this in the due course. And gastrointestinal, the nocturnal diarrhea, alternating diarrhea and constipation, fecal incontinence, postprandial fullness, tiredness, cramping, bloating, and hyperhidrosis and hypohidrosis and anhidrosis also are the symptoms of autonomic symptoms, which is very, very important. Just by history, we can conclude and try to look at the root cause and treat them. So these are the indications for which patients do you do the autonomic nervous system testing, mostly for syncope, pure autonomic failure, postural tachycardia syndrome, autonomic and small fiber peripheral neuropathies, sympathetically mediated pains, and these are all the set of patients where we recommend. So what are the tests available? Electrophysiological methods, that is heart rate recording and RR interval calculation, BP recording, parasympathetic function tests also can be done with heart rate response to Valsalva, heart rate variability with respiration, and sympathetic function tests are head up tilt table testing, Valsalva maneuver, sympathetic cholinergic sweat function test, a standard EMG instrument which can be used to measure this response, and these are all the sympathetic function tests. Just to show a tilt table test, and the normal response is 10 to 15 beats per minute increment, and thermoregulatory sweat test is another point, and elastic skin imprint is one more method where we can test. And this is a Cuisart which I stopped and clearly tells us when you suspect a peripheral neuropathy, the signs and symptoms of large fiber function dysfunction can be detected and confirmed with the EMG and CVR QST. And once it's a large fiber, and if it's a sensory component is more than the motor component, please rule out, look at this box, very, very clear secondary causes of sensory peripheral neuropathy, the familial, the B12 deficiency, folate, Lyme, the porphyrias, heavy metals, serum protein electrophoresis, TSH, burn creatinine, serum protein, cytokine A, and search for neoplasms, immunological testing. And if all these come negative, then you brand them as distal symmetric neuropathy. And in the large fiber neuropathy, if there is moderate or severe motor signs than the sensory symptoms, then you assess and distribute. If distal GM1 antibody negative, then it goes to distal motor neuropathy. And if it's positive, you go to distal motor neuropathies of other causes. And if proximal and distal family history, immunological testing, and if non-diabetic, again, diffuse motor neuropathy, CIDPs can be concluded. This is what you should approach in a gist. We can talk about this slide really talks about the assessment and neurological deficits and classification of various neuropathic syndrome. And to end my talk, just to talk about the the management, of course, it's out of focus of this, out of scope for this topic. It's an exclusive separate topic. I'm sure all of you understand, but please exclude the non-diabetic etiologies before treating the patients and stabilize the glycemic control. And then we can look at the neuropathic pain based on the sleep disturbances or depression. Sleep disturbances, gabapentin, pregabalin have clearly shown over placebo, they gave about 80% relief. And this is the treatment combinations we give. And when the anxiety, autonomic activation is there, anxiolytics will definitely help. Again, depression component, the tricyclic antidepressants and SNRIs and gabapentin, pregabalin definitely works. And this is what we should, but again, I'm emphasizing non-diabetic etiologies to be ruled out, stabilize the glycemia, and then treat the neuropathy. People will definitely respond. Thank you very much for the patient hearing.
Thank you, Dr. Srinivas Murthy, sir, for that presentation. Now the session is open for discussion. As we are running short of time, we have one question. I have got a question here from the delegate. Which among the test of awareness is feasible to or more convenient to do?
Tilt table test, sir. That's the commonest one which we can do and can be done very conveniently at most centers.
And one question to you, sir. What is your comment on very early initiation of insulin? We wait for don't wait for an HbA1c of more than 7. Shall we initiate a very early initiation if it's possible? What is your comment on reducing the peripheral neuropathy?
Yeah, it's a double-edged sword. I am sure all of you are experiencing that when you initiate insulin, the neuropathy symptoms worsen. So the easiest method is to prime the patient, tell them, educate them that your neuropathy pains will worsen for a few days and then you come back, and that is what you should. But early initiation of insulin before the DPN sets in is definitely a worthwhile advice. I would say I would jump and give anybody who's 8% and 2-drug failure the basal insulin or the premix. We can definitely start in such patients for sure.
Thank you. So as we are running short of time, we are closing this session. Thank you, Srinivas Murthy, sir.
Thank you, sir. Thank you very much.
Thank you so much. Over to Veena. Thank you, sir.
Thank you, sir. Now I invite Dr. Vasudevan Peti, Head of Department of Urology, Government Medical College, Trivandrum, to chair the next session. Please, sir.
Yes, thank you. So it's my pleasure to invite Dr. Deepak Jumani, who is a constant presence in all the annual conferences of Jpef. He is a senior sexual health physician and counselor, Sri JJ Group of Hospitals and Grant Government Medical College, Mumbai, and Police Hospitals, Mumbai. He always has interesting things to tell us about the medical management of erectile dysfunction. Over to you, sir. Welcome, Dr. Deepak Jumani.
Thank you, Dr. Vishwanath Potti, and thank you, Jyoti, for inviting me here and giving me an opportunity to share my views, thoughts, concepts, and passion. I was very happy to hear Dr. Shashi Tharoor aware of the complications, but he forgot the most important and the commonest complication of erectile dysfunction, which I find is too common in all of us. Anyway, I pray to God for safety of all, and I thank my teachers.
आप मेरे को WhatsApp करिए, वो ही phone करेंगे आप.
And I thank my teachers, Dr. Shashank Joshi, O.P. Kapoor, and Prakash Kothari, and I beseech them to bless me always. Our Prime Minister, Narendra Modi, had to unfortunately do lockdown. And it is his lockdown which has made us see each other today. It is very fortunate of us that we are under his care, under his this thing, that we are safe today. But what I want to say is this lockdown, if we look down, we will be really happy, as to how happy we are. We are with our partners, we are caged in the home, and we have a good opportunity to share our intimacies and private lives together. So that's a good thing. That's another big boon for all of us. To understand the medical treatment of erectile dysfunction, we need to understand that erectile dysfunction is a endothelial dysfunction. Because endothelial nitric oxide synthetase, which is secreted from the functional endothelium, allows the nitric oxide, which is the chemical chemical currency to enter into the corpora cavernosa cell and do everything possible to see that the blood remains inside the penis and the man gets erection. But this is all due to cyclic GMP, which makes the whole smooth muscle relax and the blood to remain inside. But this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5. So if at all you want to treat erectile dysfunction, basically you need to understand the whole mechanism begins from the endothelium. So that's why we call erectile dysfunction as an endothelial dysfunction. So, and we all only have today PD5 inhibitors, which are in the form of sildenafil, tadalafil, sildenafil, and vardenafil. So that's it. We still do not have guanylate cyclase activators or these things. We do have nitric oxide donors. We are working on how to improve the endothelium, which I will allude it to a little later. So endothelial derived nitric oxide is now proven to be an anti-atherosclerotic molecule. It is also an anti-thrombotic molecule because this nitric oxide, which is the chemical currency, the male chemical signaling molecule, it declines as we age. At the age of 60, it will be only 15% left with us. So it's very important for us to understand that we need nitric oxide throughout our life to be sexually active. I define erectile dysfunction as psychovascular, neurohormonal, iatro, and genetic issue. If we do not want ED, we should know what is ED first. Genetic cause has been now diagnosed very well because we have found on chromosome 6, there is a transcription factor 1 as SIM1 gene, which is associated with significant risk of erectile dysfunction. We find erectile dysfunction not only in diabetics, but in younger patients. And that's because of cigarette smoking, and endothelial damage is also seen due to air pollution, which is very common. And this affects mainly the older people and even the children also. Most important thing is that 70% of men have comorbid cardiovascular disease, all those patients who have erectile dysfunctions, and 50% of mortality in our country. And there has been a strong relationship between erectile dysfunction and subclinical cardiovascular disease. In fact, there's a window period of about 3 years to 5 years from the onset of erectile dysfunction to any cardiovascular event. So this could be a very good tool to stratify treatment for cardiovascular disease or assist patients who could be getting critical ailments like myocardial infarction or stroke in their life, because ED precedes coronary artery disease by more than 2.5 years in most of these patients. We find diabetics, be it type 1 or type 2, both have an increased risk of 50% and more in men with diabetes worldwide. We studied at KEM in diabetics had erectile dysfunction, early ejaculation, and low desire. And females already had low desire, and depression was the most common thing which we studied in our patients. The pathology of what happens because of diabetes is very well explained by having elevated glycated end products, increased levels of oxygen free radicals, impaired nitric oxide synthesis, endothelin B receptor binding sites increase, upregulation of ROA, neuropathic damage, and impaired cyclic GMP. So these patients need to be managed. So what do we do? Whether the problem is between the male and the female, but what we need to understand, the treatment or the counseling of both the couple has to be done. A couple has to be called together, be it menopause or andropause. There is a couple pause. So counseling between the two couple together has to be initiated. We have to rule out the psychogenic cause by asking two things. One, look at his age. If he's less than 40 years, and if he's getting early morning erections in the past 15 days, at least once or twice, he is got psychogenic or situational erectile dysfunction. He does not need PD5 inhibitors. He just needs counseling. There are two validated questionnaires which we use, IIEF and SHIM5. We advise on the patients to do avoid smoking, have a good diet, exercise, blood pressure, cholesterol, feet and eye and oral hygiene has to be examined every time when they come to you. We also do an office sildenafil test by giving 50 milligram of tablet of sildenafil or giving intracavernous vasoactive drugs like papaverine, and ask the patient to sit for a while, for 1 hour or so. and stimulate himself, and if he gets erection, he's got purely psychogenic issues. We have found a new study which says that salivary tumor necrosis factor alpha, which is present in the saliva, very simple to detect by a swab. This could be a marker for severe erectile dysfunction in a man. Additional tests we do are all these. There has been a strong relationship between platelet and lymphocyte ratio. A ratio of 105 shows that he has got minor, mild, and if it is more than 106, he's got moderate ED, and if it is more than 136, it's got severe. A very simple mental calculation you can do by doing a CBC of the patients, and then you can identify that these patients are having erectile dysfunction. Skin autofluorescence, by keeping a hand on the age reader, can also give you the idea of how much severe the erectile dysfunction is there in the patients who are diabetics. How do we treat? We have 3 lines of treatment: oral drugs, counseling, and lifestyle measures. Second line is injection of papaverine in the intracavernous tissue, counseling, and lifestyle measures. If all these fail, we put our patients into for vacuum therapy or intraurethral prostaglandins. If all these fail, we send our patients to the androsurgeon, who treats them with penile implants, and that's a surgical procedure. But if you see, friends, counseling and lifestyle measures are the mainstay of treatment for erectile dysfunctions. We have now more than 20 years of experience, and what we have learned, that counseling in the beginning itself can improve the adherence of the drug treatment, whether he's got diabetes, hypertension, or any other metabolic syndrome. We need to counsel them very well. Mindful based group therapy has been very proven. And what is more important, besides the pharmacotherapy, lifestyle changes and counseling has to be done together. Lifestyle should be your medicine, whether you are Hindu, Muslim, Sikh, whatever it is, but that has to be your religion. The first religion has to be diet, exercise, adequate sleep, and medication, which my teacher, Dr. Shashank Joshi, also mentioned in his inaugural address. We have 4 PDE5 inhibitors. All these PDE5 inhibitors, amongst them, the shortest duration of action is of vardenafil, and the longest duration of action is of tadalafil. The new kid in the block is sildenafil, which the action lasts for at least 10 to 12 hours. Otherwise, sildenafil, vardenafil have the same duration of action. Tadalafil has the longest duration of action. There have been enough studies in diabetics with tadalafil, even if the patients are having HbA1c above 9, or even if they have hypertension, or even if they have prostatic hypertrophy, tadalafil low dose works very well. So chronic therapy with PDE5 inhibitors in diabetics is a wonderful thing. There are a lot of patients who are not responding to PDE5 for various reasons. They are not stimulating themselves. They are not taking adequate dose. They're not giving enough time before the meals and before they're taking the tablets. They're taking on heavy meals or with alcohol, or sometimes their partners are not interested. So they tried giving tadalafil low dose with sildenafil, and they studied alone tadalafil 5 mg. They found better improvements. And there have been definitely dropouts in patients who are taking PDE5 inhibitors, almost 4% every month, and 50% of the patients don't take the treatment of it. We have all these PDE5 inhibitors, but what these PDE5 inhibitors do, they have got a lot of side effects: flushing, headache, congestion in the nose, dyspepsia, visual disturbances, priapism, some cases of malignant melanoma, episodic. We have contraindications, mainly is the use of nitrates and certain anatomical penile defects or retinal injuries. There have been no case where patients have lost their visual acuity. All these symptoms which occur are transient. We have also seen patients having central serous chorioretinopathy with tadalafil, but that is again transient. It reverses once the patient stops the medications. To avoid all these things, we have now films available of sildenafil and tadalafil, 50 mg, 20 mg, fast acting, avoid the liver transport, and less side effects of these patients have been there. So what's new? We have novel molecules now available. The first one is avanafil, SLX 2104, mirodanafil, and we also have lodanafil. These are newer molecules. The advantage of avanafil will be it can be also given to patients who are on nitrates. Only caution is that nitrates has to be stopped on the day when he takes avanafil. We have also found a glycyl trinitrate gel now applied on the shaft of the penis 4 times in a week for 4 weeks, gives improvement in the erectile function. There have been newer studies of low intensity extracorporeal shockwave therapy and platelet-rich plasma, which have been tried with beautiful results. But yes, we still need robust data to prove this to be a real good treatment for it. We have lots and lots of medical treatments which will now be soon coming in the market, but they are all in the pipeline. Amongst them, two things which I would like to mention is stem cell therapy. There have been 3 studies published for diabetics having erectile dysfunction, and gene therapy was studied long time back by Dr. Andrew Melman, who studied 24 stubborn diabetics with ED, and he treated them with them and they are better. Some landmark and path-making innovations which we find is, this is a beautiful study, elevated pigment epithelium-derived factor, which is present only in diabetics having erectile dysfunction. It is not present in non-diabetics. It is not present in diabetics without erectile dysfunction. So this pigment, if we block it, these patients will see improvement in the endothelial dysfunctions. It has been studied extensively, but we still need to have more data on it. So the lessons we have learned, that if we block PEDF, and it could improve the endothelial dysfunction, which will also mean that it will improve the other metabolic syndromes also, be it diabetes, hypertension, etc. So this is one therapy which can cure erectile dysfunctions. We have buried penis syndrome, which is our paper. We have 1 gram of metformin, sesame seed oil, and L-arginine gel, which we apply on the shaft of the penis. And these patients within 6 weeks can see their penis. In 24 weeks, they can have a better view of their own penis, and with PD5 inhibitors, they can have good enough sex. But these drugs don't improve the desire. There are 40% non-responders because of low testosterone in them. How do we overcome this gap? We can combine testosterone with PD5 inhibitors, has shown fantastic results. My friend Dr. Paresh Dandona published beautiful paper with his studies. He says that the diminished androgen, estrogen receptors and aromatase levels in hypogonadal diabetic men. And he supplemented these patients with testosterone, and he found within 23 weeks of testosterone replacement, the diabetes was reversed. Now, once the diabetes is reversed, the symptoms of the complications also. We have phytonutraceuticals which have come in the market, and they have fantastic combination of L-arginine and fenugreek, along with PD5 inhibitors, work fantastic in our patients. Fenugreek is known to replace the globulin-bound testosterone and make free testosterone more available because of the similarity in the chemical compositions. My friend Dr. Jyothidev published a beautiful study with patients whom he put on insulin pump, and he found beautiful improvement in diabetics having erectile dysfunction by studying IIEF scores. Mediterranean diet helps very much. Metformin, if at all we have to give our patients who have erectile dysfunction, diabetics, put them on metformin, because metformin is now studied to improve the endothelial health, and it can be given as an adjunct to arteriogenic ED. SGLT2 inhibitors, by its class effect, reduces hyperglycemia, hypertension, dyslipidemia, loses weight. And these patients, if you give them SGLT2 inhibitors and metformin, they get physiological reactions, erections. They do not need PD5 inhibitors. So that's how we can manage avoiding patients taking PD5 inhibitors and give them a physiological erections. So we need to understand what should we give to our patients. If we want to give them symptomatic treatment, yes, give them pharmacotherapy. But if you want to cure them, yes, phytonutraceuticals and regenerative medicine is a must. What should be the ideal prescription? Yes, counseling, lifestyle measures should be the first step. You can give them OHA and insulins, whatever. But if you prefer OHA, you give them metformin and SGLT2 inhibitors. Statins are a must. Antihypertensives, put them on ACE inhibitors or ARBs. If at all be beta blockers, give them nebivolol. If at all you want to give them diuretics, endopamide is the best. Low dose PDPA inhibitors if he has got no contraindications. Low dose testosterone if no contraindications, and monitor the PSA very well. L-arginine supplement with fenugreek and zinc is a must. Nutritional intervention counseling. 1 minute,
Excuse
1
me,
minute,
sir.
give me 1 minute only, 1 minute. And advise them on mental checkup. Diabetologists should learn all these things. My take-home message is the onus of sexual health is with the physicians. We need to understand most of the issues are behavioral. Only the dietary problem, healthy diet is what we are lacking in our patients, because of which we get cardiovascular disease, because of which we get diabetes. So Cleveland studied that if you intervene
Thank you, Dr. K. Jumani, sir, for the wonderful session. To chair the next session, I'm inviting Dr. Chako Varghese, sir, who is a senior consultant nephrologist at GG Hospital, Thiruvananthapuram. Welcome, sir. Hello, sir. Sir, are you there? Sir, Chako Varghese, sir, are you there? Okay. Okay, sir, we shall move on with the discussion then. Sir, we can start the discussion, sir. You can ask questions.
Hello. Are we proceeding with the discussion? Hello.
Sir, I'm sorry, we have Dr. Georgie Abraham, sir, who
Yes.
is going to be presenting the next session. He is going to be presenting the topic of diagnosis and management of kidney and urinary tract infection in diabetes. Dr. Georgie Abraham, sir, I invite you please to start the presentation. Thank you, sir.
Good afternoon, and at the outset, I want to thank Dr. Jyothidev, Sunita, and the colleagues for this wonderful opportunity to be on digital platform. And as we all know that, the diabetics with urinary infections face a lot of challenges, and there is increased morbidity and mortality. So I shall dwell on the anatomy, pathophysiology, diagnosis and management of kidney and urinary tract infection. On the right-hand side, you can see the kidney with the male genitalia. You have the prostate and the long urethra there. And on the left-hand side, you can see the kidney with the bladder and the short urethra there. And so when the infection is in the upper part of the urinary tract and the kidney, we call it as pyelonephritis. And when the ureters are usually infected with pyelonephritis, you call it as uretritis. And when the lower urinary tract is infected, you call it as cystitis. And in males, you have prostatitis. And both males and females, you have urethritis. So a urinary tract infection is said to be complicated if it is in the upper tract, the person has diabetes mellitus, the person is pregnant, the person is male, the person has a weakened immune system, as I'm going to dwell on the patients with chronic kidney disease as well as transplant, and because of another illness that is immunocompromised situation. So when you look at that, you can see that the bacteria can come to the urinary tract through various routes. And the next one will show that. And this is a picture taken from the nephrology, dialysis and transplantation, our editorial on urinary tract infection. So the infection can come to the kidney through hematogenous spread, Staphylococcus and E. coli. It can come through intrarenal reflex. You can see the reflexing ureter and the kidney getting infected, and also the parenchyma getting infected. And you can also have a poorly functioning bladder, as in a neurogenic bladder. And bacterial invasion is aggravated by a number of patients who are on catheters, either for a short time or a long time. And then in main, you have prostatitis. And as you get old, you have prostatic hypertrophy in males, and bacterial colonization and ascending infection due to E. coli, enterococcus, as well as Pseudomonas aeruginosa, because females have a short urethra, and fecal colonization can lead to urinary tract infection, especially in those with poor diabetic control. So this is a index case which we recently had. This is Mrs. V, 58 years old, 12 years diabetes mellitus, hypertension. I just want to show you that their serum creatinine level, 2015, it was 1.6 when she came to us. She had coronary artery disease, double vessel disease, and a stent was put in, and then she is lost. She comes back with an unstable angina, and then they had to redo the PTCA to the LAD. Creatinine has gone up. Then she comes in 2018, lack of follow-up, with a creatinine of 2.6, and then she presents recently with a serum creatinine of 11.6. She had pyelonephritis. You can see the CT scan there. The left kidney is enlarged. This is the left kidney, and the right kidney is small. And what you can see is there is hydronephrosis in the left kidney, and also there is hydroureter in the left kidney, which is the enlarged kidney. And you can see thick bladder wall in the CT scan. And so she had E. coli, she had a tender left kidney, fever, and LV function was normal. The procal was 111.4, and she had a DJ stent put in. We had to dialyze her, and after the DJ stent and with the use of the antibiotic, we cannot use amikacin in this situation. The culture pattern is given here. So she was given one of the carbapenems, and her kidney function improved. She became dialysis free. So this suggests one of the complicated urinary infections in a patient who was lost to follow-up. Her sugar was never under control, and this is one of the complications which increase the morbidity and mortality in a diabetic patient with pyelonephritis. So this is the kidney biopsy of a diabetic patient who had recurrent pyelonephritis, male patient. You can see, for your information, this is the tubule with the cast, WBC cast, mixed cellular infiltrate, pyelonephritis, which is an infection of the kidney, parenchyma, and the pelvis. So you can see that a lot of mixed cellular infiltrate, suggesting a kidney infection in a transplant patient with functioning graft. So we had to reduce the immunosuppression. At the same time, we had to give him antibiotic therapy. So diabetes mellitus, diabetic patients have higher risk of infection with more risk of morbidity due to many factors, due to uncontrolled diabetes mellitus, impairments in humoral immunity, polymorphs, lymphocytes functions are less, decreased random motion of neutrophils, chemotaxis, phagocytosis, and microbial killing mechanisms, and glucose levels in genital tissue enhance yeast addition and growth. Long-standing diabetes mellitus causes vasculopathy with poor tissue perfusion, and diabetic neuropathy results in delay response. So this shows that diabetes mellitus is a risk factor for urinary tract infection in both males and females. The green bars are the diabetes one, and the yellow bars are non-diabetic. So you can see that at every age group, from the age of 18 to 75, you can see that there is an increased incidence of urinary infections in diabetes in men as well as in women. It is much higher. You can see that the percentages are much higher irrespective of the age group, and an estimated 50% of the women report having had a UTI at some point in their lives. This is a cartoon which shows the urinary tract infection depending upon the age, 0 to 75, and you can see that you have this is female and these are the males. So males may get prostatitis at a younger age, and the females during the reproductive age period they have increased infection, and then after menopause they also get infections, and if you are a diabetic this is much higher. So predisposing factors, urinary infections are urinary stasis, as happens with, I have shown you the picture of one of the patients with bladder dysfunction, neurogenic bladder, foreign bodies, anatomic factors which are congenital, that is either a polycystic kidney disease or you have a uretrocele or you have a reflux, and acquired factors such as stones and papillary necrosis, factors compromising immune response, functional disorders, and other factors. So pathophysiology of UTI, the urinary tract above the posterior urethra is normally sterile. Several mechanical and physiologic defense mechanisms include normal voiding with complete emptying of the bladder, uretrovesical junction competence, and peristaltic activity that propels urine towards the bladder. Antibacterial characteristics of urine are maintained by an acidic pH less than 6, high urea concentration in normal renal function, and abundant glycoproteins that interfere with the growth of bacteria. These defense mechanisms assist in maintaining the sterility and preventing UTI. So this cartoon shows the symptoms of urinary tract infection. You have acute pyelonephritis. The patient presents with fever, malaise, nausea, vomiting, abdominal pain, and pyonephrosis or perinephric abscess. You can see the perinephric abscess in this cartoon. Rigors, low in pain, scoliosis, low in swelling, weight loss, and night sweats, and lower urinary tract infection. They have dysuria, frequency, hematuria, cloudy or offensive urine, nocturia, suprapubic pain, strangury, and urgency. So assessment and diagnostic findings. History is very important with clinical manifestations. Urine tests includes urine analysis and urine culture. And for a urine culture, you take a midstream clean catch sample, which most of us do not do that. We don't explain it to the patient how to do that, especially with female patients. Collection from a urinary catheter by aseptic technique in patients who are catheterized. Suprapubic aspiration may be necessary in some instances when you are getting mixed organisms which are contaminated. And also, I would suggest that a lot of the patients or a subset of patients in our country do have co-infections with Mycobacterium tuberculosis, which I have also seen in my practice, for which an early morning sample of the whole urine may be sent for AFP smear and AFP culture. Sometimes you have to send many samples may be required, and blood culture in pyelonephritis and fungal culture in immunocompromised patient with diabetes. So other investigations are an ultrasound is a non-invasive imaging test for size, shape, and obstruction. X-rays are not performed on pregnant women. Presence of radiopaque calculus may be seen. An intravenous pyelogram, limited value with kidney insufficiency. CT KUB, as I have shown, be used to check for kidney stones or other obstructions. CT with contrast when you have normal renal function, if kidney functions are normal. MRI for detection of kidney abscess, because to detect an abscess, you may have to use an MRI or a CT with a contrast. A PET scan may be useful in certain, and cystoscopy may have to be done in certain instances, and avoiding cystourethrogram to look for vesicoureteric reflex. So investigations, midstream clean catch urine sample in a sterile container and expedite transfer to the microbiology unit within 1 hour is required. In patients with an indwelling catheter using sterile technique, the catheter pot is cleaned with alcohol and urine is aspirated from the pot using a needle and syringe. Urine from the urine collection bag must not be used as a sample. If there is a delay, it can be refrigerated up to 2 hours. If there is further delay in transport, the sample should be stored in a container with preservative. The sample should be a minimum of 50 cc. In questionable cases of lower UTI, which yields spurious culture results, suprapubic aspiration is necessary. Urine microscopy is very important to look for WBCs and CAS. When there are WBC CAS, it suggests that it is a pyelonephritis. And then urine culture. Urine culture remains the gold standard and method in diagnosing urinary infection. In females, for the diagnosis of cystitis, a cutoff of 10 to the power of 2 colony forming unit per ml is required for diagnosis compared to a value of 10 to the power of 3 for cystitis in men. So what is uncomplicated UTI? The organisms are E. coli and shown here Enterococcus, Klebsiella pneumonia, Proteus mirabilis. Complicated UTI is similar to this, and they are antibiotic resistance, E. coli and Pseudomonas, and catheter-associated UTI are Proteus, Providentia, and Candida species. And recurrent UTI, you should look for Proteus mirabilis and Klebsiella pneumonia. So this busy diagram, this busy graph slide shows you the antibiotic therapy and uncomplicated, complicated UTI in ESBL, E. coli, asymptomatic bacteriuria and UTI in pregnant women, and then acute bacterial prostatitis and chronic bacteria. All these should be of short duration, except in pyelonephritis and renal abscess. It should vary from 14 to 21 days or even 4 weeks. And the culture and sensitivity pattern will describe what should be the antibiotic in that particular institution and for that particular patient. So antibiotic for asymptomatic bacteria and cystitis in pregnancy, include nitrofurantoin, amoxicillin, amoxicillin clovelenate, cefalexin, cefadoxime, phosphomycin, and trimethoprim. Most of my patients, we give them nitrofurantoin as oral dose, and duration for in patients with the kidney injury, if the estimated GFR is less than 60 ml per minute, nitrofurantoin will not work. So the continuous antimicrobial prophylaxis regimens for women with recurrent urinary tract infection, the expected UTI in some women, they get a recurrent infection, so they have to be treated, and maintenance have to be maintained sometimes for 6 months or more than that, and the antibiotic list is given here, including trimethoprim, nitrofurantoin, norfloxacin, ciprofloxacin, etc. So post-coital antimicrobial prophylaxis regimens for women with recurrent urinary tract infections, they also include nitrofurantoin, trimethoprim, ciprofloxacin, and expected UTI per year. It is shown here the numbers, and I wouldn't go into detail of this. So the lower urinary tract infection, 3 to 5 day course, and phosphomycin in certain instances you may have to give 3 gram as a single dose, and usually nitrofurantoin for 4 days, and upper urinary tract 14 days minimum treatment in certain patients with the renal abscesses diagnosed by CT contrast or MRI. You may have to give it for longer time depending as per the local culture and sensitivity results. Please tailor the therapy. So high-end antibiotics like as colistin, polymyxin B, meropenem, imipenem, ertrapenem, vancomycin, and other drugs may have to be used in recurrent urinary tract infections and also in patients who are immunosuppressed, as we see in our transplant patient. And please use the UKD EPI formula to see that what should be the dosage adjustment given for the patient, and depending upon the dosage adjustment, the antibiotics has to be administered. So prevention, adequate and frequent water intake has shown to decrease the frequency. Few studies have demonstrated that post-coital voiding has reduced in the introduction of organism. Cranberry juice or tablets have been shown to prevent the addition of bacteria to the uroepithelial cells. Menopause changes in vaginal microbiota and lower lactobacilli leads to vagina acting as a reservoir for UTI. Probiotics can help in restoring the balance in the microbial environment. Tropical estrogen or estrogen agonists increase lactobacilli in the vaginal epithelium and decrease the vaginal pH. Vitamin C and D have been useful in reducing recurrent UTI. Ascorbic acid causes acidification of the urine and also has bacteriostatic effect. Antibiotic prophylaxis is used in addition to behavioral approaches in 3 or more episodes of UTI per year with the use of low-dose trimoxazole, fluoroquinolones, or nitrofurantoin for 2 to 6 months. So my conclusion is prevention is better than cure in diabetics with appropriate blood sugar control. I have shown you the first case, the report where my own patient never turned up, no diabetic control, coronary artery disease, lancet with pyelonephritis. In recurrent UTI, in diabetics, look for acquired structural abnormalities, neurogenic bladder, papillary necrosis, stones, co-infection with mycobacterium tuberculosis, very important, and sexual practices. Prolonged prophylaxis in recurrent UTI. Thank you for your kind attention.
Thank you very much, George Abraham, sir. And now we have the next session. Since we are running out of time, we are continuing to the next session. This is the Gold Symposium, GLP-1 outcomes and latest developments. For that, moderation of the session, I'm inviting Dr. Jyothidev Kesavadev, who is the chairman and managing director of Jyothidev's Diabetic Center, Tirunelveli, Kerala, and Dr. Anand Pillai, consultant and interventional cardiologist and electrophysiologist at Anandapuri Hospital, Tirunelveli. Welcome.
Thank you, Dr. Yasin. So joining me is Dr. Anand Pillai. So he has informed me that he is a little bit busy and he is in the ICU. So let us begin the show. So we have the symposium on GLP-1 outcomes and the latest developments. So this is a Gold Symposium. So this symposium is defined as a Gold Symposium since we know that the treatment of diabetes is going beyond the treatment of glucose. So probably we have been treating diabetes for so many years now, and repeating the same mistakes again and again can never be considered as an experience. So that is what the GLP-1 era has taught us. And the gold standard GLP-1, that's liraglutide, has been in the market, in the open market for more than a decade now. So we have two prolific speakers in this symposium. The first one is going to be Dr. Rajiv Agarwal from Meerut, and he is a noted personality from our country. He is in the Limca Book of Records for implanting the maximum number of free pacemakers in India. Wonderful. And he has been awarded the Amar Ujala National Excellence Award for the Lifetime Achievement. And again, the Inspiring Doctors of India Award from Economic Times in the year 2018. And he is going to speak to us on the sweet spot, cardiovascular risk reduction in diabetes. Over to our speaker, Dr. Rajiv Agarwal.
Just let me, yeah.
Yes, sir.
Just a minute, just a minute, just a minute. I'm not getting slides on the full screen. Can I have a slide bigger than this? Because my slides are very small.
You can drag, sir.
Yeah, this is better. This is better. I think I am both visible and audible to the audience. Thank you very much, Dr. Jyothidev, for involving me in this wonderful symposium. And you said it is a gold symposium. So it makes me a little bit nervous that I have to dig out some gold out of GLPs. I am an intervention cardiologist, and like many other cardiologists, we are barging into diabetic territory. So let me start the story. We have heart and diabetes, we have sweet spot, we are searching for CV risk reduction, and naturally we are trying to understand the mechanisms of these wonderful drugs, how they work. As you know, diabetes is one of the biggest menace of this century. If the person expectedly have a life of around 60 years, if you have diabetes, you have deletion or ablation of 6 years of productive life. If diabetes is complicated by vascular disease, one loses around 12 years of life. So we are trying to make it understand to all of us that diabetes, once it is with vascular compartment involvement, we lose some life. The risk of diabetes with CV risk is very, very high because 80% of patients with diabetes are overweight, they are prone for vascular compartment involvement, they have arterial hypertension, and they have dyslipidemia, which creates a common soil for development of vascular compartment entrapment. You know that CKD, heart failure, diabetes, ASCVD, it has become more or less a common cell hypothesis that diabetes and vascular compartment, they go hand in hand. This is a very recent review why Southeast Asians are more prone and why we create a perfect storm for such an accelerated response of diabetes in our vascular compartment. This is a very recent publication, I think about a week back. I will not dwell upon the finesses of this article because that is a different area altogether. What interests me as a vascular biologist dealing with coronary arteries, I want to make it clear that diabetic atheroma is a different disease altogether. Because of inflammation, we are prone for more acute coronary syndrome. Because of new vascularization, we are prone for vasa vasorum enlargement. Sometimes the plaque rupture may start from outside to inside, and more collagen layout that causes more restenosis. So diabetes has got a very complicated problem. You are more prone for developing acute coronary syndrome at the same time. These interventions do not last long because of neovascularization. Another very interesting thing to look at it, the microvascular involvement. If you have one microvascular bad involvement, the the risk is so much. If you have two, then three, then there is a correlation that number of vascular bad in microvascular compartment, more the number, more the poor outcome. And retinopathy is almost always associated with nephropathy. These two compartments, they go hand in hand. But the story doesn't add at microvascular compartment because we have a macrovascular compartment involvement also. If there are polyvascular disease, what we call as cardiologist, if you have diabetes, stroke, and MI, on top you are the worst. So the moment disease become in macrovascular, polyvascular, that means if you have peripheral arterial disease, cerebrovascular disease, or coronary artery disease, what we define as polyvascular disease, we are in great problem. And if we both have micro and macrovascular disease, then the trouble is not double, it is many, many fold. And looking at it, a very simple diagram, which all of you know more than what I know, if there is a microvascular compartment which is debilitating, not life-threatening, is glycemia related, but it is preceded by macrovascular compartment complication. So if you have a patient who has got microvascular compartment, I strongly feel these are the patients whom we look for macrovascular involvement. And we should never miss this step. Another very good understanding that even patients who are children born out of diabetic parents, even if they are normoglycemic, their endothelium dependent vasodilatation is poor. That means the vascular compartment involvement starts even before dysglycemia. And this is the summary why cardiologists are poking their fingers into diabetes, because whatever you do, whichever way you do deal with these patients, the diabetic patient do worse than their non-diabetic counterpart. So that is a big challenge to diabetologists and cardiologists or a vascular biologist, because that is how we have to make that a non-diabetic patient in their vascular compartment should become non-diabetic. And I am very honest that till today we have not been able to achieve it. With this background, let us go for searching this sweet spot for CV risk reduction. And the story begins now, how we are going to deal with it. You know, there are various mechanisms. Glycemic control is one. But what has happened best is in 2008, with rosiglitazone story, the FDA has given us a mandate that patients should not be controlled only on diabetes, but they should be controlled in terms of vascular compartment. This is guidance to the industry in 2008, and there we started a new era called glucocardiac-centric era, or a vasculocentric approach to diabetes. That is why we are here to play and interact with you, because we have to see how we can deal this problem jointly. And there are two studies, LEADER and EMPA-REG, each one of you know. And this is a follow-up for 3.8 years, it is 3.1 year. My interest is this. Prior CVD was present in 81% of the patient, while it was in EMPA-REG, 99% of the patient. Roughly about 20% of the patients in LEADER are not vascular patients, which were there in EMPA-REG. So there is slight disadvantage to LEADER in terms of atherosclerotic burden to outcomes, because had LEADER been something like EMPA-REG, 99%, I will say, I believe that the result of LEADER would have been more powerful than what we have today. And this is a very important slide. It shows inconsistent directional discordance. You see the stroke incidence increases in EMPA-REG, and while it is consistent directional concordance. So we know that in EMPA-REG, there is slight dissociation between vascular bed and a coronary bed, while there is a concordance in leader. That is a very strong point to carry home. Another good thing is the EMPA-RAG, the result, they start within a month or two, they start separating out, but in leader, they start significantly at 1 year or so. And those who follow lipidology, they know that is how statin trials behave. They do not behave that this curve, they start separating within weeks or months. So this is some kind, SGLT2 inhibitors are some kind of neurohumoral modulator, if you permit me to say, like eplerenone. But leader is behaving, liraglutide behaves on atherosclerotic compartment, something like statins, because they work on atherosclerotic compartment, which start separating out a little bit late. And when we compare these drugs, liraglutide, empagliflozin, and sacubitril/valsartan, there are 3 new molecules. We find these drugs, they stand the test of time, and they are comparators to each other, complementary to each other. They are not competitive. Look at the all-cause mortality, look at the CV mortality, look at the sudden cardiac death. They are all favorable, both liraglutide and the EMPA-RAG. So I'll say this drug is comparator to rest of its newer friends like empagliflozin and sacubitril/valsartan. This is a new study, Swed-Heart study, where they have shown patients who were given liraglutide in hospital, they start separating out fast within 6 to 8 months, and they continue to diverge like a crocodile mouth. So this is a real world data which shows liraglutide, when used in acute MI, it works wonderfully well. Liraglutide improves the infarct size after ST segment elevation. It causes less of reperfusion injury, even in non-diabetic patients. So we are in an era like EMPA-RAG in diabetic heart, non-diabetic heart failure. Similarly, we are getting some signals that liraglutide can affect the vascular compartment even in non-diabetic patients. It improves the infarct size. This is a global increase in LV ejection fraction. There's liraglutide and placebo. Those who are going primary PCI, justifying that liraglutide is affecting the vascular compartment positively, even in acute coronary situation. The situation for SGLT2 inhibitors is not same. There is not much data. There are consensus opinion that it can be used in acute MI, but most of the time the drug is allowed to be used post-discharge. But unlike that, liraglutide can be used during in-hospital acute coronary syndrome. This is another study which shows that type 2 diabetes mellitus, with or without established cardiovascular disease, they both have favorable outcome. This is just 2020 publication. So again, going and extending that, if you are high risk for developing coronary artery disease and diabetic, liraglutide can be used safely with outcome benefit in a patient who have not expressed disease. This is a summary from McMurray and Christensen, appeared in Lancet last year late, and it showed that liraglutide, when the GLP-1 receptor agonist, not liraglutide specifically, they do benefit in all the outcome related parameters. Just see. If we look at the 3-component MACE, if we look at the cardiovascular death, if we look at the fatal, non-fatal myocardial infarction, fatal, non-fatal stroke, all p-values are significant in this meta-analysis. And this is very, very reassuring. Another way to look at it, all-cause mortality, hospital admission for heart failure, composite kidney outcome, including macroalbuminuria, worsening of kidney function. Again, the p-values are significant, although largely the volume of data is in favor of SGLT2 inhibitors. If we have macroalbuminuria and renal eGFR issues, they have more volume and more strength, but in this meta-analysis, they have equally performed well, all GLP, when we take into consideration. This is a heart failure study. There are short trials, Unfortunately, they both are associated with increase in heart rate, and these trial, Life, Fight, and LIRA heart failure 2D, they have not shown advantage in heart failure. So I'll stretch myself in saying that in heart failure, the meta-analysis has shown advantage, but largely my choice of drug will be SGLT2 inhibitor, not GLP-1 receptor analog, but they are not harmful in heart failure patients. This is another study, and you must have seen that since it increases the heart rate, this is subgroup leader study again, that patients who have 10 beat per minute increase in heart rate, there is no difference in MACE and hospitalization heart failure. So heart rate does increase with liraglutide, but the outcome is not different. That is just about a couple of days back. This is number needed to treat, a temporal analysis, and this is again a very good study to see that number needed to treat keeps on decreasing once we follow these patients for longer length of time. And this is what you see, that number needed to treat keeps on decreasing. Number needed to harm initially is low, but as we follow 3 years across, it is roughly around 150, which is very, very satisfying. If you look at the blue at leader, number needed to treat keeps on decreasing over a period of time, although the liraglutide was 3.8 years, but this is a projection that this will be the likely number needed to treat. So it is assuring that over a longer follow-up, these molecules are going to give us better outcome rather than decrease, and number needed to treat keeps on decreasing. So to summarize, that SGLT2 is more on pump, and GLP-1 receptor analog more on ASCVD pathway, and that is, I think, is more of a consensus. So the mechanism behind these drugs are multifold, and since these drugs are new, we are not really sure that everything we know is good or bad, but there are some understandings which we have to listen to. And you can say it decreases body weight, blood sugar, blood pressure, and lipid metabolism, and it is how, and what is next we are trying to learn is the inflammation. And these risk reduction are independent of metabolic parameters. So there is some kind of pleiotropism we have to understand, that they are not metabolic or glucose reduction properties which are translating into the outcomes. And this is a summary how we look at it, what we achieve. And this is a reduction in systolic blood pressure with liraglutide. And this is a brief report which shows that the effect of liraglutide and in sustained 6-semaglutide are independent of baseline blood pressure. That is again very, very important thing, that the outcomes are not related to the baseline blood pressure. I am actually getting, this is a slide which I wanted to show, a very recent publication, that the outcomes are unrelated to the baseline blood pressure, both in terms of systolic and diastolic blood pressure. This is the effect on lipid profiles. And so the next issue which has come up to our understanding is inflammation. And that is a very hot thing in cardiology, because residual risk can only be addressed by inflammation. It reduces preclinical evidence of anti-inflammatory effects of GLP-1 receptor analogs in labs, and we have some evidence in clinics also. This is the upcoming trial which will do FDG scanning of a hot plaque, and we will be able to see whether the inflammation is reduced in vivo. It is not in vitro. In vivo, whether we are able to reduce inflammation in a plaque. This is all the biomarkers. You can see that they are reduced favorably, and that is how probably it works. This is summary of the effects, that there are multiple ways. When you have many, many ways, probably we have multiple ways, multiple pathways, and many of them are still unknown. The molecular mechanistics are very, very simple. When they work on the gut, they reduce inflammation, they reduce lipid deposition, they decrease plaque lesion development, decrease inflammatory pathway, and that is why they are very important asset in dealing with atherosclerosis in diabetes. This is many direct effects. These receptors are more expressed than SGLT2, so their effects are more systematic than the SGLT2, which are confined to less vascular bed, predominantly to gut and kidneys. This is a low burden of atherosclerosis development when liraglutide inhibits progression of the atheroma. The only thing which I am going to show is that it causes increased sympathetic system activation where there is no activation and increase the heart rate. That is one thing which we have to keep in mind. And these two molecules are complementary. They are not competitive. They are working on two different axes. That's why we should not carry away there is a conflict between these two molecules. And there is a host of new investigations being done to understand that how GLP-1 receptor analog can work in HIV, osteoarthritic, chronic obstructive lung disease, liver disease, Alzheimer, tobacco dependence, alcohol dependence, craniopharyngioma, because they are expressed in brain also. This is an algorithm which is very, very recent from American Society of Nephrology, and I think it is a very comprehensive, very simple, and it is ready to use for us. If you have diabetic kidney disease, eGFR is more than 30, you go to SGLT and then add on. If the eGFR is less than 30, probably GLP-1. High risk of heart failure, yes, you go for SGLT2, but they are not harmful in the presence of heart failure. If you have ASCVD, you can go for GLP-1 earlier than SGLT2. If you have UACR more than 30 SGLT2, if it is less than 30, then it is GLP-1 because their albuminuric effect, hypoalbuminuric effect are less pronounced than SGLT2. If you have metabolic risk, again, the GLP-1 receptor analog are preferred. If you have none of them, they are probably not recommended. I think to my mind, this is the most simplistic and clinical approach to use these molecules, and I find there is no conflict between the two molecules. So again, showing that if GFR is less than 15 to 30, then GLP-1, they are drug. Otherwise, if albuminuria is more than SGLT2, then this is the way we look at it, and simplistic I have expressed it. The use of glucagon-like peptide receptor, this is again a very recent publication, again saying that these drugs are complementary and they can become partners in managing vascular nuisance. So establish atherosclerotic disease, cerebrovascular disease, eGFR less than 30, then we will go for GLP-1. And if the complication, they trouble you, comorbidities, obesity, frequent genital mycotic infection, osteoporosis, history of fracture, lower limb ulcer and amputation, probably this will be our drug of choice. So I find there is no conflict. They are complementary. This is update, you know more than me, and they also say that if there is atherosclerosis, probably the GLP-1 receptor analog liraglutide is a better drug to be used. This is recommendation that patient with type 2 and establish atherosclerotic CV disease. And that is what is going on, that in a metformin naive patient, there is an emerging consensus guideline directed opinion that you can display GLP-1 receptor analog as a first drug to tame the vascular compartment problem. This is navigating through the maze. Again, GLP-1 receptor are predominantly specific to atherosclerotic CV events, non-fatal MI, stroke, and death. By contrast, they have significant effect on non-fatal MI, they do not have effects on non-fatal MI and stroke, that probably the myocardial pump, they affect more, and the pipes are affected more by GLP-1 receptor analogs. They are both class 1A indications. Now, this most important issue, what my panelists said, that why they are not being used, who will bell the cat? I think this is the responsibility of cardiologists, endocrinologists, and more responsibility of us, because patients.
Excuse me, sir, we have only 2 minutes left.
Yeah, just I am winding up. So instead of using therapies which diminish return, like if you see 3-fold more likely to get DPP-4 inhibitors, 7-fold more likely to get sulfonylurea, and 8-fold more likely to like insulin, despite having such a strong indication of being used, we are underperforming. They are like statins, they are like antiplatelets. They have to be used very aggressively, and once again saying they are complementary to each other. And the usage is both in UK and US is less than 10%. And that is why this Gold Symposium encourages us, shows our responsibility that physician inertia is to be handled, and we have to use them more liberally so that a community is benefited. And this is Dr. Braunwald, who is a father figure in cardiology. So now he challenges that cardiologists have to learn more of diabetes, because the vascular compartment can only be tamed if we use good anti-diabetic drug. And he has coined a new term which is called diabetocardiology. I'll just wind up on this, that the lifestyle modification continues to be very, very important. And GLP-1 and SGLT2 receptor, SGLT2 inhibitors are not competitive. They are not conflicting. They are cooperative to each other and complementary. And we have to profile a patient where which drug comes first, and probably the second drug will automatically come later on. And that is probably the need of the hour. And we have not to forget that these drugs should never be missed, underused, and they should be given, displayed to our patient population as much as possible.
Thank you very much, sir, for that session. For the next, to invite the next speaker, I am inviting Dr. Anand Pillai, sir. Anand Pillai, sir.
Hi, thank you. First of all, thank you, Dr. Rajiv Agarwal, sir. Am I audible?
Yes, you are audible.
Okay, great. A very exhaustive update on SGLT2s and GLP-1 analogs, particularly differential indication in terms of cardiac and renal, when to pick which drug. Thank you so much, sir. I think we'll come back to you with the panel discussion. Next, I would like to invite the next speaker is Bhattacharya, sir, from Bangalore. Sir is a consultant in the Department of Diabetes and Endocrinology, MHB, Professor of Endocrinology, JJMMC, Devangiri, Karnataka, as well as co-chair of Shiva Jyoti. Sir will be talking to us on addressing the elephant in the room, therapeutic inertia in comprehensive management of diabetes.
Thank you. Can I share my screen? Is that full screen you can see now?
Yes, sir.
Just a minute. Let me just get my. This is a hop screen. I think you can see. Why it is not moving?
Yeah, it is visible. It's a
yeah,
screen.
But there's something is coming. It is correct. I need to go to the share screen again.
I'm not sure if it was shared by you or from the Jpef main media board.
Yes, sir, we have shared it.
Okay.
Now the full screen.
It is in full screen, sir.
Okay, fine. Thank you. Thanks very much. Namaskar. I'm Dr. Bhattacharya from Bangalore. Jyoti must have, thanks Dr. Anand. We have a lot of positive points taken from Rajiv. Jyothidev thought that I'm very strong man, so I'll take the big elephant outside the room because elephant is very heavy and it requires something big, big input. So my idea of taking further about the GLP-1 receptor analog, that's sort of the topic on therapeutic inertia and how it can help. This is some of my disclaimer. I did participate and I do participate till now on the clinical trials in the different phases with the different anti-hyperglycemic agents, including insulin, GLP-1 receptor analog, and IDEG expert. We did work with clinical development program on liraglutide. I'm a member of some admode companies, but I don't have any share in pharmaceutical company. I take the responsibility of the text of my talk, and our focus today is on GLP-1 receptor analog. So I'm going to take how it can take the elephant away. Okay. There's some WhatsApp news is going on that the rare positive thing about the webinar is that it doesn't have any take-home message since you are already at home. But I'm sure after listening to Dr. Rajiv and hopefully when I go through, you will get some take-home points which help us to serve our people better. Most patients with type 2 diabetes do not achieve HbA1c goal. This is enhanced data. It may be quite old. You may tell it's a 20 years data, but you see that 30 or 40% of the people, our HbA1c target is less than 7%. If you do a country specific.
Excuse me, sir. I don't think we can see your slides moving, or is it just me who is seeing the same slide?
No, it is moving. My computer is moving.
Okay. Can the organizers confirm if it is, they can also see it moving?
We can see the CV slide now.
This is the most patients with the type 2 diabetes slide. Can you see this?
Yes, yes, sir.
Yeah, my computer is moving nicely.
What is on your screen right now, sir?
Most patients with the type 2 diabetes do not achieve HbA1c goal.
No.
Okay, what I am seeing is one rare positive thing about webinars. That slide is what I'm seeing.
So that is the last slide. Now I've got to this slide. What do I do now?
So can you just escape?
Please wait, sir. We'll check. We are checking on it.
I'll escape.
Yeah,
Okay.
skip a slide and go to the first slide once.
Go to the slideshow.
You can close the slide first, sir.
Can you let sir share his own slides, because I think he is not controlling the slides at this point.
No, it is moving.
Yeah. I think Jyothidev sir has to close the slide if he is not sharing, so that you can shut down the PowerPoint and then you share from here.
No, I have already shared.
Can you stop here, sir?
1 minute. Where am I now? I'll do the share screen and it is coming against share.
Yeah.
So basically I've stopped already.
Yeah, now you can share, sir.
Now I can share. I need to open the slide again because I have closed after you have told. Okay, I've done the share screen. Can you see my first slide?
Yes.
Yeah, now
Yes, sir. Yes.
you can go for the presentation view, full screen.
Yeah, I've done the presentation view. I'm taking a cursor. Where is the cursor? Presentation views.
Yeah, now it is presentation view.
That's fine. Okay.
Yeah.
Now it's moving.
Yes, sir.
Okay. So most patients, 15 to 20 years old data, most patients are not reaching. And if you go to the country specific, if you start from the England wells, you see what is the percentage of the people are not achieving at all. That's a big number. About US, Europe, Canada, Latin America. And these are some of the data from our hospital, the Manipal Hospital, Bangalore. This is one of the, they're quite a bit old. In our OPD, I agree this is a tertiary care hospital, more complicated patients you see, there is no doubt about that. Hardly 40% of the people HbA1c less than 7%. We have done one hospital survey which showed 13% of people HbA1c less than 7. Another one showed average HbA1c of 2,245 for people when people are admitted in the hospital are 9.1. So basically, we are quite far off from our ideal targets. So the question comes that why people with type 2 diabetes do not reach their therapy goals. And the potential reason is clinical inertia, that elephant. I need to take this out. And that's the agenda I thought I'll talk. Therapeutic inertia, the barrier to comprehensive diabetes care, choosing the therapy to achieve a composite glycemic outcome. I will explain what do I mean by composite outcome. And then I will tell you a pragmatic study on lead-up prime study quickly through how it can help whatever Dr. Rajiv tried to propose. Barrier to comprehensive care, therapeutic inertia, how do I define? This is a therapeutic failure to achieve objectives within a reasonable period of time. Now, what is reasonable period of time? You can individualize depending on the person sitting in front of you. Or failure or delay in the treatment intensification among the patients who do not achieve the treatment goal. As a general practice, and we all know this type of slide is seen that prevalence of diabetes is increasing hugely both in men and women. And our standard WHO and IDF data tells that about the people died of diabetes, HIV, say 1 million. 0.7 million HIV, 1.2 million tuberculosis, 0.4 million malaria. So it's a big burden about the people atherosclerotic disease and uncontrolled diabetes. Causes, there are a lot of factors out there. Lack of knowledge or negative attitude of the evidence-based guideline, suboptimal doctor-patient communication, patient characteristic, and the problem of clinical and organization context. But the issue is very clear. We always used to think that I am Mr. Perfect, the person sitting in front of me not following me. That's not right. Actually, studies have proven that the clinical or therapeutic inertia, 50% are because of healthcare professional. You and me need to take the responsibility. 30% for the patient, 20% for the healthcare system. If I can go one by one, I'm trying to move a bit fast because we started a bit late. That provider level, okay, we have a problem with the time, different demands. We don't want to implement particular guideline. We have a perception of side effect, but last three are very, very important and absolutely correct. The studies show the fear of weight gain, fear of hypoglycemia, fear of injectable therapy. These are main concern to barrier to get a good glycemic control, which we all need to take the responsibility. But 30% is because of the patients. Some of them are too much kichi about the side effects. Before taking everything, they will take hundreds of things. They will take 100 of cola, Pepsi side effect. Nothing will happen. Pani puri, no side effect there. But when I give you medicine for diabetes, doctor, are you sure this medicine doesn't give a side effect? And this is a part of a group of people. Misunderstanding of treatment regimen, multiple morbidity. You'll have to accept. The comorbidity is a big issue. Polypharmacy is a big issue. People are afraid of needle. Acceptable. Nobody likes to inject. Who will like to inject? Unless you are, nobody wants to see a doctor unless you are in desperate need. Injection-related anxiety, fear of self-monitoring, and pill burden if you are on multiple tablets. But the system level, we also need to do. Although my slide showed 20% is because of organizational defect, our health infrastructure, we need to improve. Forget about others, we need to talk about our country. The Corona COVID-19 pandemic had showed very clearly we are crap. Our infrastructure of the health as a part of the nation is crap. We need to improve. We spend hardly 1% of our GDP on the health. This has to change. No point in blaming doctors, no point in blaming patients. And the population level benefit in terms of prevention and management diabetes are huge. Just we need to implement simple things like a lifestyle modification. We are talking big about prevention diabetes, but we need to implement that from the beginning, probably from the school and the community level. We need to address the strategies so that our awareness improve, the health education improve. We are not talking about the qualification improvement. We agree there are limited availability, there are some cost of medicine is there, but I think one other good way we will do that the digitization, the people's data in the database, that helps definitely to give forward. We all the time we get the data, how much we are doing, that will make us move further in a better way. So what are the solutions now about therapeutic inertia? One, we can choose a pharmacotherapy which achieve most of the things that we want. See, diabetes is not only HbA1c control. Dr. Rajiv has clearly showed about pipes and pumps. We need to get through and comfortable with the clinical guidelines, whichever is practical, implementable, and possible and affordable in our setup. And we need to intensify and the treatment as early as possible. We used to tell about hit hard and hit early so that the control gets better. So let's come to this composite endpoint. The composite endpoint important is that is not only the HbA1c control we are talking. We have a lot of other things. We can't just have a single endpoint to see, well, this HbA1c, whether you are alive or dead, your heart has gone, brain and doesn't matter, your HbA1c 6.9, I'm very happy. This will not work. And we need to look on all the issues at minimum HbA1c, less hypo or no hypo, and no weight gain, or preferably weight loss, along with atherosclerotic cardiovascular improvement and renal benefit, cardio-renal benefit. So these will tell us about the composite endpoint. Now, we have seen this slide plenty of time. This is short-acting GLP-1, long-acting GLP-1, SGLT2 inhibitor, DPP-4, sulfonylurea, TZD, insulin, and you are taking the same points, nothing extra we are talking. HbA1c, hypoglycemia, weight, cardiovascular effect, and what are the main important disadvantages. Every molecule has disadvantage. But see in this, how many reds are there, which we don't like, and how many greens are there, which we love it. And this is what a long-acting GLP-1 analog scores about all other molecules. Now, this we have seen about different pathogenetic mechanisms of diabetes. So we need to tackle each and every one, starting from pancreas to liver to brain to muscle to kidney to fatty tissue, intestine, and as you see, most of them are actually taken care of by GLP-1 receptor analog. And that's how the benefit is seen. We have a short-acting exenatide and lixisenatide we hardly use now. We have an intermediate-acting, probably liraglutide you should tell, and the longer-acting like dulaglutide, albiglutide will not get, semaglutide you hopefully will get, and this has not yet come yet. So if you see the glycemic control, the different RCT, the randomized control trials and the real world evidence, the clinical development program from monotherapy to add-on therapy, metformin, sulfonylurea, thiazolidine, insulin, and so on. The deep blue one is liraglutide 1.8 milligram. That is the perfect dose if the patient tolerates. And see the HbA1c reduction is 1.5, 1.6 in that range. If you see the real world studies from the HbA1c lowering, and some of them are actually quite a bit more or less, we can certainly tell they are above 1, probably approaching 1.5%, which is good. Then a comparative study with the different GLP-1 receptor analog. If you see that, the blue color, again, 1.8 milligram of liraglutide scores quite high in the different in comparison to the others, as is the number of people achieving the glycemic target. Here we are trying to see how many percentage of the people getting HbA1c, 7%. As you see, most of these countries are quite a big number. Some HbA1c less than 7%, that's a big target. And that's what we tell. When you compare it, all the molecules, little older data, all the molecules here, 60% of the people which can achieve HbA1c correctly. And if you see all three factors, HbA1c less than 7, no weight gain, no hypoglycemia, liraglutide 1.8 milligram is the best in comparison to all other molecules. Well, pleiotropic effect, Dr. Rajiv has clearly mentioned, that's exactly the same thing, total cholesterol, LDL, and triglyceride, liraglutide, systolic, diastolic, BP. I'm going to go quickly on this, and cardiovascular biomarker like PI1, BNP, and high sensitive CRP. And that's ultimately giving us an anti-atherosclerotic effect. That's what we learned from the last session. So if you see the ideal anti-diabetic drug to achieve a composite metabolic outcome, so for the glycemic efficacy concern, fasting sugar, PP sugar, and HbA1c. So for the hypoglycemia, less, weight gain less or weight loss. Preservation beta cell function is a bit of conceptual thing. a cardiorenal benefit, and certainly this is the correct molecule to choose from. Now let us see from a pragmatic trial which has just been presented in the virtual ADA in last month, LIRA prime study, what it tells very quickly. So this is a pragmatic clinical trial. There is a difference between a randomized control trial and the pragmatic trial. The main difference, as you all will be knowing, that here the strict criteria of inclusion exclusion is very strict and you can hardly anything do. Not flexibility is very less. But in the pragmatic trial, we can recruit more people in a broad indication to get a better introspection about the molecule. So that's what we tell here, full spectrum of intervention and everyday clinical practice, whether it actually works in the real life situation or not. So what we have done here, type 2 diabetes, more than 3 months, HbA1c 7.49, only on metformin, one arm continued on OAD, discretion on investigator. We have added alpha glucosidase, gliptin, meglitamides, SGLT inhibitor, SU3ZD, whatever investigator wanted. And other arm on the metformin, we have started on liraglutide and up titrated 0.6, 1.2, 1.8, depend on the tolerability. So this one is liraglutide on top of metformin. This is OAD on top of metformin. Okay. Now the primary objective is to see the glycemic efficacy. Okay. Now this is the different definition. Time to inadequate glycemic control as defined HbA1c more than 7 in 2 scheduled clinic visits, 2 visits consecutive in the first 26 weeks. All these are important. That's what the graph I'm going to show. The first 26 weeks, how many people did not achieve the glycemic control, that is less than 7%, in the 2 consecutive visits? And the secondary outcome and other things we are comparing to the other groups. The secondary endpoint, HbA1c without weight gain, glycemic parameter, and the safety parameter. We obviously will be checking about hypoglycemia and adverse reaction which leads to discontinuation of the trial product. This is a multinational project and India did participate. We have nearly 10% of the 2,000 people who participated, who completed the LIRA prime trial. This is our baseline characteristics. Interesting to see, as I was telling, between pragmatic and RCT, very rare few RCT you will be seeing that females are more than 30%. Here nearly 50% of the female patient. Age is that our daily people around 57. Body weight, BMI is a bit overweight. Diabetes duration around 7 years. HbA1c average are 8. And metformin. More than 900, nearly 900 people in each group as metformin, either 1.5 gram or more. And this is what we see in our practice actually. After metformin, what next? The doubt between a gliptin and SGLT inhibitor and the LIRA prime trial, it was left on the investigator choice. So 48% people on SGLT inhibitor, 40% people on gliptin, and rest on the others. So this is just like in the OAD arm, metformin plus OAD arm are exactly like your and my clinical practice. And this is what we see, the result. The cumulative incidence plot time to inadequate glycemic control. So here, whichever curve is lower, that is better. So this is our liraglutide, the blue one, and the green interrupted and OAD. As you clearly see from the 26 weeks onward, whenever we started the statistics, that liraglutide arm, just metformin liraglutide, did much better than the other arm, significantly lower glycemic control. If you try to see the difference between liraglutide and OAD arm, liraglutide reduced 0.3% HbA1c more, fasting blood glucose around 12 milligram, this is a millimole, body weight 0.6 kg more, and systolic diastolic BP did not change much, but there are a lot of statistical significance in all the parameters for the weight and fasting sugar and HbA1c is concerned. And if you see now as a proportion, see the white one is the liraglutide and the green one is the OAD arm. So HbA1c target less than 6.5%, LIRA is better than OAD. HbA1c reduction less than 7% without weight gain, LIRA is better than OAD. HbA1c less than 7% without hypo, symptomatic hypo, LIRA is better than OAD. And if you see all 3 points, LIRA is better than OAD. So this pragmatic trial clearly showed just adding LIRA on top of metformin is much better than adding any other OHs on top of metformin. That's what exactly we could document in this. So in the conclusion, this study showed very clearly in a primary care environment when metformin is inadequate to keep a control of the patient with the type 2 diabetes, adding liraglutide compared to OAD, number one, patients spent significantly longer time with adequate glycemic control. Number two, there is superior glycemic control. Number three, more patient reaching HbA1c target. And the number four about weight and hypoglycemic benefit. So that's the agenda I started, addressing the elephant in the room, therapeutic inertia, comprehensive management of diabetes. I think liraglutide has proven as a strong molecule to push the elephant out of the room or to push the therapeutic inertia out of the room. And in summary, is therapeutic inertia is a significant obstacle to reaching the glycemic target. All of us understand very well. Achieving composite glycemic outcome is the key for comprehensive diabetes management. And the GLP-1 receptor analog help patients achieve a composite glycemic endpoint. And newer routes of administration, that is the way forward. Now we have initially exenatide, then liraglutide, then dulaglutide, now semaglutide injection. Now we are going to get, and trials have been completed on semaglutide, oral semaglutide, that pioneer rate of series is already been licensed abroad, but India it has not been licensed. That will be wonderful to get the oral molecule of GLP-1 receptor analog. So at least the people who are afraid of the injection, they don't want like injectable, for them, it will be a wonderful molecule to reduce the therapeutic inertia. My sincere request, be safe. We are going through a very hard time. We follow common sense and we need to win this battle of COVID-19. History is in our favor. That used to happen in big kingdoms and in heaven also, probably. That's Deborah Jindra. And this is happening here. And as you believe, WHO recently tells it is actually everywhere. So we need to put the mask. And also we need to make the social distancing is very clear. I do understand the left of the slide, there is a social distancing is going on. But the right of my slide, I don't know what is this girl actually is doing. Whether she is trying to keep a social distancing because she has a fight with boyfriend or husband or brother and so on. But let you and me practice social distancing, practice sanitization, and use the mask in everywhere to keep ourselves safe. Thank you very much for your attention.
Thank you, sir. Thank you for that great review, particularly on the therapeutic inertia topic. And I actually would like to congratulate the Jpef team for adding this topic, the therapeutic inertia topic, because I think that is probably diabetes being one of the most important public health issues. Despite all the new drugs and strategies that we have, the biggest burden I probably think is the therapeutic inertia is a reason that majority of the patients who need to benefit from what we know is not getting benefited. I'll move on to the panel discussion and bring up a couple of relevant points. I'll start with Bhattacharya sir himself, connecting the two aspects that he talked about, one about the therapeutic inertia, and a second about the overwhelming evidence supporting GLP-1s, particularly in terms of reducing cardiovascular morbidity and mortality. So this is a health economics question connecting the two. So the question is, despite of such overwhelming evidence in favor of GLP-1s, how much do you think is the actual penetration of GLP-1s across the country? And how much do you think, and I honestly think that it is very low and probably has to do with the fact that it is quite an expensive drug, which probably only mostly the upper class patients can afford. I know that the health economist will make an argument saying that it is upfront cost to bear, and on the long term you will save up on preventing the complications. But the upfront cost, is it something that our patients are able to bear, and how much is the cost a big therapeutic barrier as far as the penetration of GLP-1 analogs are concerned?
Yeah, that's what I tried to tell about the cause of therapeutic inertia. I think a state or government has to take the responsibility, not that everything the patient and the doctor will tell. See, that's the reason I told you that 1% of the GDP we spend for the health, and that's exactly what is happening now. Nowhere we are getting bed, nowhere the infrastructure is so poor. We need a lot of input. Just blaming the doctors and the healthcare workers and beating them, nothing will be achieved. I completely agree with you. If you consider the out-of-pocket cost, it is a costly medicine. Even if I am practicing in Bangalore, our clients are supposed to be a better socioeconomic status than national average, then also certainly it is a big point, no doubt about that. We doctors as a healthcare professional, we can't do anything. So it'll have to be done from the state. State has to take the responsibility of our health. And most of the people with the diabetes, they will not die of diabetes. They will die of diabetes, atherosclerotic cardiovascular disease, renal disease, and the heart failure. And that's what we need to understand very clearly.
Thank you, sir. I'll come back to, is Dr. Rajiv, sir, still with us?
Yes.
Yes, sir. Thank you, sir. A question to you. You had very nicely contrasted GLP-1s and SGLT2, particularly from a cardiovascular mortality standpoint. And I think you did allude to how to pick each one in circumstance, but for the benefit of the audience, in a simple way, how are you going to pick between these two, particularly when you're primarily looking at a cardiac patient, MI patient with diabetes? How will you make a decision, leaving the cost aside? How will you pick, when will you pick GLP-1 and when will you pick SGLT2?
That is something I think, let me say, it's kind of carry-on message what Dr. Bhattacharya showed. If you have an expressed atherosclerosis and diabetes, there is no discussion which is the molecule. The molecule is GLP-1 receptor analog. And the good thing is, unlike SGLT2, you can use this molecule in the CCU bed. That is what I do. I do angioplasties. I tell them this is not a sugar injection, this is a heart injection. And that will save you from angioplasties, because large number of my patients understand that they have to come back. So once you give them this impression that this is an injection will keep them away from a cath lab, is very motivating to the family and particularly the wife. And once the other extreme is there is a patient who has got diabetes, atherosclerosis, and cardiac failure. Then they go probably one by one as you can go about. So my bias towards GLP-1 is probably it should be a molecule like a crash cart treble molecule, where every patient post angioplasty, post CABG should be given in hospital liraglutide. I do not know why it is not being done at our end, but it is done in my place in cardiology. And if you are dealing with cardiac failure because of LV dysfunction, probably SGLT2 will come first, and second choice will automatically come, the other molecule will come a second choice. I think I am relatively clean, simple. And if you are complicated by low GFR, less than 30 kind of thing, GLP-1 comes. If you are higher than this and albuminuria, probably SGLT2 will come. If you have an obese patient, weight reduction is more with GLP, so you will go for this. And most of our patients are obese. So I'll say in my coronary care unit, if I am dealing with atherosclerotic diabetic patient, I start post angioplasty, post CABG, post procedure, acute MI, every patient on liraglutide.
Thank you, sir. Very key message for all the audiences. So much of choice at this point, and the risk profile of the patient. There are so many different variables to consider, as sir had just mentioned. So these days, you cannot blindly start an OHA or a drug. There are so many different risk profile to really study the patient in depth to figure out which one they will benefit from the most. I just have one more quick question. Is a very mechanistic question to again Agarwal sir. Contrasting the microvascular and the macrovascular complications, do we know what is the differential determinants of these two? Why do we have macro coming in earlier? And then why is it that the previous OHAs had some protective benefit to the microvascular but not macrovascular? And then the newer drugs currently have been shown to have a macrovascular benefit?
You see, you have to understand the basics of atherosclerosis. The microvascular is a capillary damage. It is not pronounced atherosclerosis. While macrovasculosis is atherosclerosis, there is a lipid hypothesis, there is hyperinsulinemia. So there is a background which starts, like I say, what I say, I mean, you will all agree with me, the diabetes in terms of vascular compartment starts at least 15 to 20 years before glycemia comes. Hyperinsulinemia, dyslipidemia, atherosclerosis, they start before in macrovascular compartment, and the moment glycemia comes, the microvascular compartment comes in. So my message is, the moment you get a patient of retinopathy or you get a patient of nephropathy, don't forget heart, because that is a killer disease. And that is what we have to pick up, that these patients should be subjected to treadmills, risk assessment, whether they are dealing with, we are dealing with hidden atherosclerosis in macrovascular compartment. The problem with macrovascular is it kills. It does not debilitate, it kills. So apart from the glycemia part, because these drugs are vascular drugs, they are not hypoglycemic drug to that extent. So probably their effects is more on vascular, macrovascular compartment rather than microvascular, because microvascular is,
we have only 1 minute left now.
Yeah, microvascular is more of glycemia.
Thank you, sir. You have very nicely made the distinction, and I really appreciate that. We are almost done. If the other panelists have any last questions, we can take that. If not, we can wind up. Any other questions from the panelist?
Thank you very much. Thank you, Dr. Bhattacharya, Dr. Pillai, Dr. Ajay Kumar, Dr. Jyothidev, for providing me this opportunity. I am at least 2,000 kilometers away from you. Thank you.
Take-home message that pipes, pumps, and composite outcome. That should be the 3 points. If we can remember, that's wonderful. We are successful in this symposium.
Thank you, sir. I'll just have Jyothidev sir wind up the session. Sir, please.
Yeah, thank you so much, Dr. Anand, for joining us. And it has been a very brilliant session by both the speakers, Dr. Rajiv and Dr. Arpan Dev, and sharing not only the science but also their own personal experiences. And definitely GLP-1 is a gold in the treatment of not only diabetes but also in the prevention of cardiovascular diseases in diabetes. So thank you so much, and we are moving on to the next session. Thank you.
Thank you.
Thank you, sir.
Thank you very much, sir. Thank you to all the speakers and moderators. It was a beautiful symposium. Up next, we have the Jpef 2020 theme symposium. It's time to target. And for that moderation, I'm calling Dr. Benshi Sabu, sir, who is the president of RSSDI and president of Aero India. He's the chairman of Diabetes Care and Hormone Clinic, Ahmedabad. Welcome, sir.
Has Dr. Benshi joined? I can see Jas over there. So let me find out.
I think
Jyoti,
yeah, Dr. Benshi has joined. Yeah, Dr. Benshi has joined, and so we have introduced you as the president of RSSDI and one of the lead authors of Time in Range, and we are moving on to the theme symposium. That is the time to target symposium. That is the theme symposium for 8th year of JPF. And over to Dr. Benshi for moderating the session.
So first of all, Jyoti, it's great pleasure for me to moderate a very interesting and very important symposia where we have our close friends. I can see here Jez, she is very much here. Tade had already joined, I think. So we start with first session. Can you just share the screen for the CV of Dr. Tade?
The first session is going to be from me.
Okay, sorry.
Yeah.
Yes, sorry.
So
the first session is with Dr. Jyothidev. I'm sorry for that. Okay.
Yeah, no problem. It is going to be very big. The first session is going to be very basic.
Dr. Jyothidev, I don't think anyone needs introduction of Dr. Jyothidev in India. He's very well-known figure in India. Dr. Jyothidev is a senior consultant and diabetologist from city of Trivandrum. He is has a endocrinology training at Mayo Clinic, US. He is FRCP from London, Glasgow, and Edinburgh. He is fellow of American College of Endocrinology. He is also a fellow of American College of Physicians. He is fellow of RSSDI and fellow of Diabetes India. He is a chairman of Jyothidev Diabetes Research Center, Trivandrum. He is a vice president of Aero Kerala chapter, which is a Indian Obesity Society. He has reviewed multiple papers, more than dozen index endocrinology journal and diabetes care journal where he is reviewer. He also published multiple papers in technology, and recently his paper, which is use of continuous glucose monitoring, intermittent use of continuous glucose monitoring in type 2 diabetic patients. Today, Dr. Jyoti is going to talk about connecting glucose, connected glucose meters and insulin pen, the future. So over to Dr. Jyoti.
So thank you, Dr. Benshi Sabu, and I am delighted to be a part of this special symposium where Dr. Tadej Batilno from Ljubljana, Dr. Parthaka from United Kingdom, and Jazz from Ahmedabad. So all of them are going to join. So I am going to have a very brief discussion on a basic topic in technology. So these are my disclosures. So the question here is, why are we still missing the target in diabetes therapy? So time and again, we were exploring the newer modalities of treatment. We were just listening to the Gold Symposium, the GLP-1 Symposium. So almost all these therapies are available in India. So we have all technologies and therapies in India, but still we are missing the target in the majority of our patients. The reasons could be multiple. It could be because of inertia. It could be because of the wrong glucose readings. It could be because of the old meters or non-adherence to the advices on behavior or the advices on drugs, or it could be because of the fluctuating glucoses due to late initiation and intensification of some therapies, or it could be because of the traditional glucose readings being written on a piece of paper or on a diary. So what can be a solution? What can be a realistic solution? I believe that a realistic solution, especially during this COVID crisis, will be the use of friendly, very simple, inexpensive solutions. Because today I was observing, we are having a virtual platform, and so many doctors are finding it very difficult, even when there is no login name. We took away the login name and the password. Even then, many doctors are finding it difficult to locate the screens, to locate the screen and so on. So I'm receiving many doctors unable to log in, despite the fact that there is no login credentials required. So if that is the case with we doctors, then look at our population at large. So if you are introducing something new in technology, the winning statement will be, it should be user-friendly and very simple. So what are these connected insulin pens? So these connected insulin pens and the connected glucose meters are meant for making our life very simple. So these are the pens equipped with the near field communication technology. Some of these pens have Bluetooth enabled caps in it, and these are allowing the capture of the data from another device. And this should eventually allow automated insulin dosing and delivery. So these are some examples of these connected insulin pens. You have NovoPen 6 over there, and this is NovoPen Echo Plus. And these pens are some of these basic modalities. They have 800 injection dose memory. And since it is NFC, no recharging is necessary. It has a remarkable 5-year battery life. And this one, the Echo Plus, is meant for kids. And even it has the capability of half a unit dosing. And it will have the memory of the last injected, size of the dose, and the time since last injection, and the amount of active insulin, that is insulin on board. So the connected pens, what you see over there in this picture, you have the NovoPen 6 and then the Gluco or the Dyson platform, or it can be replaced with an ordinary mobile phone where you have the NFC enabled in it. And this will result in integration of insulin injection data into the platform. So the connected pens, the insulin pen data will sync with these devices or with the apps. For example, My Sugar app, that is the app with the maximum number of patients using all over the world. Or it can be Accucheck SmartPick software. Or it can be any continuous glucose monitoring devices. It can be Dexcom or Medtronic or Abbott. So all of them have now collaborated with insulin device and insulin manufacturers to result in the so-called integrated digital diabetes ecosystem. So this is an emerging new system where there is automatic tracking of the insulin dosing data. There is automatic tracking of the CGM. So we have the Bluetooth enabled caps, and then you have the algorithm within the phone. Then you have a separate Abbott Libre sensor or another CGM sensor, and this data is integrated, ultimately resulting in automated insulin dosing. So this could be the future artificial pancreas, which can even eliminate the use of an insulin pump. And this could result in individualized diabetes management. And some of these observation studies with NoPen 6 has shown increase in the time in range. Of course, we have the next speaker, Tadej Batilno, who is a brainchild of time in range, who has joined us today. And this could result in fewer missed boluses and better insulin management. So what are the concerns of using such connected devices in diabetes? Are there any concerns? Of course, there are concerns, even with those connected insulin pens with insulin pumps. We do have some cyber security concerns to maintain the confidentiality, the integrity. And recently, DTSEC, and that is from the Diabetes Technology Society, the first consensus was published on the standard for the network connected diabetes devices. Which specifies the security requirements and the program for assessing conformity to those requirements. Because I know the patients, as well as all of us, the doctors, even when we are using a telemedicine platform or an electronic medical record which is available in the cloud, the first concern is it secure? Is the data secure? And we need to also establish the evidence on cost effectiveness, and we need to have more evidence on the research. So we need to do more research on this. So let me now discuss the connected glucose meters. It has been in India for quite some time, for so many years now. So these are some of those meters which are connected via a very simple Bluetooth technology to a smartphone. So I have this smartphone where I have the mobile app, and this is one example of a mobile app which you can see over there, which is displaying the glucose values. And the mobile app in the phone is capable of via Bluetooth capturing the glucose data and converting the glucose data into analytics, graphs, patterns, diaries, and so on. So this is how I can have a tiny drop of blood measured in this glucose meter, and within 5 seconds it will provide us with a report which simultaneously can get displayed in the mobile phone app. So both are there simultaneously getting displayed over there, and I can manually tag whether it is before the meal or after the meal. I can have the graphs, I can have the trends, and these newer glucose meters, this is a smart light feature from Contour. The green displaying that the glucose is within range, it is 93. If it is above, say 180, then it will show this amber colored light. And if it is below, then you have the red colored indication. And these newer glucose meters also will have the chance of a second chance blood glucose sampling. So if the first sample is insufficient, you will not lose the strip. You will not lose the strip. You can have a second sample. sampling. So this is the broad view of the contour connected ecosystem. The strip connected with the meter, connected with the phone, connected to the cloud. And you have the username, password. The entire data is stored in the cloud. Entire data is stored in the cloud. And this can be retrieved at any time, including in your phone or in your laptop or in your desktop. The Contour app has got some of these delightful features. You can review the results. You can add events. You have the smart alerts. The patients can have alerts, reminders for a doctor's visit. They can have reminders on when I should be measuring the glucose next, and structured reminders, and easily they can share the results. So this is one example of how you can take a picture of the food and then you can add it onto your Contour app. So you can have record events such as diet, you can manually add exercise, or you can connect it to your app in the phone. It can be a health app in your Android or on your Apple mobile. You can add medications. So there is interconnectivity between this app and with other health or mobile apps. So this is another view, another interface of the same mobile app, where you can generate a PDF diary, or you can generate a PDF report of the blood glucose data, or if it is meant for a research, I can extract a raw data file and then analyze it. So this is how it looks like over several days or weeks or months. And at the click of a button, I can message to the doctor's office, or I can email to the doctor's office or to my nurse. What about the accuracy? So this meter that I have shown you is one example of a meter which is integrated with some of these artificial pancreatic systems. Many of these insulin pumps are connected with one of these meters. So accuracy is something which is pivotal when you are using a glucose meter. Many patients and even many of our colleagues are not aware that different glucose meters are different in their accuracy, since there are so many meters available in the market. So the accuracy is defined as how close is the value to the lab standard or to the YSI standard. And this is one example of remarkable accuracy which exceeds the ISO 15197 2013 standards. So this is the definition of that accuracy, plus or minus 15 milligrams per deciliter when it is below 100 milligrams per deciliter, and plus or minus 15% when the glucose is above 100 milligram percentage compared to the reference value. And the 99% of the glucose values within the zone A and B of the error grid zone. And these meters exceeds the accuracy standards. One snapshot from our telemedicine program over several years. And this is one patient who got registered with us in 2007. And this is a postprandial glucose values. So remember, everything depends on the accuracy. So this is another example of, this is one touch, again a connected glucose meter, which is connected via Bluetooth. So this is the Bluetooth connecting with the phone, with the mobile phone app. But this one has got a reveal ecosystem where there is a web app for the patient. So the patient can himself see the different patterns. He can also assess the time in range, time below range. And there is a web app for the doctors, or this can be for the diabetes nurse or for the educator. And everything is completely secure. So again, going back to the concern on security, so these are completely secure systems. So these are quick averages, and this is in the mobile phone itself, which can show you, with the help of those recordings in the past, informing the patient on how much time it is within range, how much is below range and above range. And this glucose meter, the moment the patient is measuring the glucose value, not only it appears over the phone app, it also appears within seconds in this laptop or in your desktop. And this will enable for you to have a remote monitoring with the patient. So this is the dashboard where all the patients are listed. I can even have a filter over there to find out how many of them are having type 1 diabetes, type 2 diabetes, gestational diabetes, how many of them are having hyperglycemia. So many options are there, and that is mainly for research. And one snapshot of another patient. So this is classical example of a remote glucose monitoring. The patient need not be there coming to the hospital with a diary. So this is all electronic and remotely monitored. And this at a glance, we can identify those problem areas. So there is a problem over there. So more chances of hypoglycemia. And there is a problem over there. And this is significant glucose variability over there. So all these are possible even with some of these glucose meters. Of course, we are now in the era of continuous glucose sensors and newer modalities of insulin infusion. But glucose meters will have their own role in the management of diabetes, especially in this COVID crisis, when we are more and more adopting remote monitoring and telemedicine in the practice of diabetes. So this is a review along with Dr. Benshi Sabu, where we reviewed experiences over the past more than 15 years using telemedicine in the care of diabetes, the merits, demerits, and the challenges. And another one over 20 years on the prevention of complications in diabetes. So important. This is not with a medication. This is not with a new medication or a therapy. This is with the simple virtual consultations over a period of 19 years on how we have prevented the vascular complications, change and modification of behaviors in therapy over telemedicine. This is so. This is so. Even though we are using virtual platforms, eventually at the back end, it is again so, because this has been very successful. But do you know, this is existing for more than 9 years now. This was launched in the year 2011. And now Zoom is worth more than the world's 7 biggest airlines. 7 biggest airlines. The same is true with some of these connected glucose meters. Now is the time, though it has been available for quite some time. Now is the time we need to broadly use it as a solution for COVID, not only during this pandemic, but beyond this pandemic, since regular, systematic, structured glucose monitoring alone can save precious lives, especially during this crisis. So thank you so much. Thank you so much for your patient hearing.
Thank you, sir. I request Dr. Banshi Sabu, sir, to introduce the next speaker, Dr. Jyothidev.
But can we have 1 or 2 questions also to Dr. Jyoti?
Yeah. We can have the discussion at the end, or we can ask questions now.
Because it is all different topics,
Please,
so
please.
one, Jyoti, those patients who are not doing very regularly SMBG, and still you are distantly monitoring them through the app and all these things. Suppose he gets a hypoglycemia, what's the legal or a ethical issue with the doctor? Because this app, the patient feels that because he has done the sugar report is now, a doctor can also see. And suppose patient is in severe hyperglycemia or in hypoglycemia, what is the legal or ethical issue with that?
So this is something I think we have discussed during one of the board meetings. I remember that we should have a disclaimer. So at the moment, what we are doing is we will have a consent form before initiating them on telemedicine. So most of these patients are those patients who have been in our hospital at least once or twice. And the data that I have shown over years, more than 12-year data, these are patients who are on an in-person visit at least 2 or 3 times a year. And the rest of the visits are all virtual visits. So the patients are well trained on managing diabetes. They are empowered on managing diabetes, and they are taught on managing hypoglycemia. And even in the file, there is a write-up and a picture on how to manage and how to recognize hypoglycemia. So the legal aspects are taken care of, and the patients are also taught very thoroughly on this is an emergency. and this has to be managed immediately, urgently.
I think after the TADE talk, I will again ask you one more question. What will be the future of self-monitoring of blood glucose when you are going to use the continuous glucose monitoring so frequently? Because most of our patients are not actually monitoring 4 times or 3 times or 6 times in a day. And to get the continuous graph sort of thing by self-monitoring of blood glucose is real difficult. So we will again, yes, really. So now we have, yes. So can I have the next speaker? So Dr. Tade is going to talk about the use of technology to increase the time in range. To introduce Dr. Tade, he's like fatherly figure for time in range. It was his idea. It was, time in range was completely conceptualized because of him. He's the chairman for ATTD conference. He's a consultant and head of department of pediatric and adolescent endocrinology. And at the Slovenian University of Ljubljana, completed medical degree at University of I don't know how to pronounce this particular city name, so it's again very difficult for me, so I'm sorry for that. And he had multiple papers in different journals. He's in editorial board of Journal of Pediatric Diabetes, Journal of Pediatric Endocrinology. He was the editor of European Journal of Endocrinology from 2009 to 2015. We know him as a ATTD chairman. He is kind enough to come to India 2-3 times on our invitation. Last time we were having him at Diabetes India meeting, and he served on the European Association of Study of Diabetes and council member as a co-organizer of 13 annual meetings of Advanced Technology and Treatment of Diabetes, ATTD. Last meeting was, we were there in Spain, and next meeting will be there in Paris and France. He's a regular member of Slovenia Medical Academy and European Academy of Science and Arts. Over to Dr. Tade for the way by which how we can increase in time in range. So Dr. Tade, who is going to talk about the use of technology to increase the time in range. Over to Dr. Tade. And welcome to India. Virtual welcome. We are really missing, and I'm sure you will be missing also the Kerala and your Nagpur trip.
Yeah, so hello everybody. My warmest regards to India. I do actually miss, yes, I was looking forward immensely to visit India now in this week, and we wanted to come together with my wife, but then, we make plans and the God decides differently, so we cannot help. So thank you very much for this invitation. I'm really happy to be among you in this virtual way. And let me jump into, so those are our disclosures. What I want to share with you actually is I would like to touch the background a little bit, discuss a little bit the CGM, and then the increase of technology. Does it help? I would touch the targets, of course, and I will just touch the COVID era. That's, kind of an interesting thing for many of us. So the background is that basically in the most developed countries in the world, we don't do well. And this is the best slide, or mostly shown slide for 2 years ago on ATTD. And this is the type 1 exchange cohort. And as you can see here, actually, the latest cohort is worse, has higher A1C as compared to the cohort 10 years ago. And this was confirmed in another American study that included more, older adults. And you can see actually the Novel cohort is considerably worse, actually, than what we were used to. The only good thing is that when you go down in this study with the A1C, severe hypoglycemia is also decreasing. So the paradigm of DCCT, that the lower the A1C, the more hypoglycemia, is not true anymore. And this is very important. The question now is, are we better equipped to prevent hypoglycemia or hyperglycemia with technology? So what's more important? And here is an interesting study. It's the ORIGIN trial that was actually recalculated for hypoglycemia and cognitive impairment. And here is 11,500 people. And as you can see, actually, if you only have a non-severe hypoglycemia, it is protective. It improves cognitive dysfunction. And also, interestingly, when you go further, actually, this is a study of healthy young people that was published 2 years ago. Healthy young people, several thousand of them, and they were followed up for 30 years. And interestingly, despite the fact they did not have diabetes, they never had one single hypoglycemia because they had no therapy. The cognitive impairment was associated with glucose variability. And the fasting blood glucose in these people can only go up. There is no way it goes down. So it was the fasting blood glucose variability with, of course, going up into hyperglycemia that did the cognitive impairment. Recently, they made MRIs on the same cohort of people, no diabetes, and you see actually hippocampal damage in those that had this glucose variability. Again, no hypoglycemia because there is no treatment, no diabetes. Healthy people, just glucose variability a little bit up, and you have hippocampal and white matter damage in the brain. Another even more interesting study is a Mendelian study, which means random blood samples in 117,000 people, none of them treated for diabetes. They stratified the glucose, and look at this, if your glucose, your random glucose, is in between 6.5 and 7 point, which is actually very low, this is around 90 to 140, you already actually have a 5-fold increased risk for retinopathy. No diabetes, no hypoglycemia, because they were never treated. 1.4 increased risk for peripheral neuropathy. And look at this actually, 5 times for nephropathy, peripheral arterial disease, and also an increased, significantly increased risk for myocardial infarction. Again, these people never had therapy. This is a random blood sample in the population. We did a recent study in acute hyperglycemia, very few data. What if you acutely increase glucose? And this was done in a functional MRI, adolescents, and we clamped them from normal glucose to 20 millimole, which is around 300. And look at what happened actually. Their performance, this is the control group, and the second performance increased, but with diabetes, with hyperglycemia, it very significantly decreased. And here you see the time course, as you can see again, this is controls, and this is the second with diabetes. As you can see, actually, there is a considerable deterioration in the function, in the cognitive function in this group with acute hyperglycemia, comparable to hypoglycemia. And then, of course, if you want cardiovascular, this is a recalculation very recent from the DCCT. And again, it was the high glucose that was related to cardiovascular death, angina, and chronic heart failure. So please remember actually that it's hyperglycemia that increases cognitive impairment and cardiovascular disease. And I showed you many examples for this in people that never experienced one single hypoglycemia because they were never treated. The second thing is the CGM, and CGM is really strikingly effective. This is the penetration, a recent report for type 1 exchange, and from the German study. As you can see, actually about 50% of people are using it 2 years ago. It goes to around 60% now. And this is actually a very recent report demonstrating again the same study that when you go down with A1C, if you use real-time CGM, the severe hypoglycemia does not increase. And also, actually, as you can see here, the DCCT paradigm is over. This is a recent report from Germany, and here, as you can see, the first year of use, DKA went down significantly, severe hypoglycemia went down significantly, severe hypoglycemia with coma went down significantly, around 3,500 users in this German actually registry was enrolled in the first year. Also, the striking effect of intermittently scanned CGM in the United Kingdom. Here, actually, our next speaker, Partha Kar, has a major actually role that people with diabetes got intermittently scanned CGM in the United Kingdom. Why? Because academia, actually diabetologists, continuously demonstrated that it doesn't work for British people. And then when they gave intermittently scanned CGM to British people without diabetologists, look what happened. It worked perfectly, like with any other person in the world. So I was extremely happy to see that CGM also works in British people. You just have to remove the diabetologists. And here we have a pediatric study, probably one of the few randomized controlled trials with the intermittently scanned CGM, and again, better outcome. Finally, there is a nice study that compares all the downloads from intermittently scanned CGM in Spain and worldwide. Many downloads, hundreds of thousands. And if you compare A1C, actually, again, the more they scan, the better is the outcome, the lower is the A1C. But if they want to reach the target A1C, look, they must scan around 25 times a day, just to show how important is the knowledge about your glucose. They actually were not able, however, to reach the time in range target completely, even with 30 scans. They're very close worldwide, but not in the Spanish population. Same is true for the time below range. This is time below 70, 30 scans. They didn't reach the target, and time below 54, again, they were unable to reach the target, which is very interesting. This is very interesting. Time above range, slightly better. I'm sorry for this. Slightly better, actually. Here, they almost reached the target worldwide. So if you go actually to the GOLD study, this was actually published yesterday for those that actually want to be up to date with very recent data. This is the recalculation of the Swedish study, the GOLD 4. And what I showed here is A1C here in relation to hypoglycemia. As you can see in this study, hypoglycemia does increase with decreasing A1C. But with the A1C of 7, which is the target, this is the international target for time below 70, as you can see here, very close to the target. And when you look to the target for time below 54, below 3 or 54, the target basically can be reached. But the most interesting part is when they compared time in range and time below here 70 and here 54. And as you can see, actually, this one is almost reached when you have a time in range of 70%. And this one actually is even closer to this target. So this is the 1% target, and here is 1.1. So basically, even with the MDI, actually, you can reach both targets, almost reach both targets at the same time. The next question is the price, and this, I believe, must be extremely interesting also for India, because I know there are some states that want to start reimbursement, that want to start social services, and I really believe this is important for India. So the first is CGM, real-time CGM. This is a study from the Swedish insurance system, public Swedish insurance system. They had 500 people on CGM for 1 year. There were multiple benefits, but this one is the most interesting. So there was an immediate nationwide cost reduction of 345,000 euros. 250,000 euros was saved when they paid for this technology. Very similarly for the United Kingdom, actually, here they showed, this is the pregnancy study, the beautiful pregnancy study, they would actually save 10 million pounds if every pregnant lady in the United Kingdom with type 1 diabetes would use CGM. And finally, the intermittently scanned CGM, the Libre, this is a recent publication, also from Belgium, National Insurance System. So it helped, this is not so important. What's important is they also saved, it is cheaper, so they saved a little bit less, but they still saved 150,000 euros in the same year. So to conclude that all these technologies, if you are within an insurance system, it is cost saving for the insurer. And this, of course, is very important. And this is why now it's getting a really, really wide reimbursement in the European Union and the United States. The next question, of course, is does more technology help more? And here, actually, I prepared a calculation. This is the old studies where we had only sensors. And as you can see, all these studies, this is the randomized controlled trials, met the criteria, almost all met the criteria for hypoglycemia. None of them for time in range. If you go to a little bit newer studies, as you can see here, actually, again, all studies are getting into target for hypoglycemia. But only when you start to use the closed loop studies, you also reach the time in range target. So it looks like the time in range target is more difficult to achieve with technology. You seem to need more technology to be successful. If you go to the latest trials, as you can see, all but one, and this was actually not focused on hypoglycemia. Even this is close. 4 is the target, here it's 5. But other trials, please look, they exceedingly successful. And most of them also for time in range. So it looks like that if you use more technology, actually it's easier to get both targets. Here is the recapitulation of this data. This is CGM alone. Usual reports are up to 55. Predicted glucose suspend goes higher to 60. And closed loop, whatever kind you use, they consistently go above 70% of time in range. This is my city. It's a medieval town. It was established by the Emperor Augustus in the Roman Empire in the year 4. And it has a medieval castle from 11th century and the river and several old buildings. And this is where the first loop club, the first formal conference on closed loop was held in 2003. And now what we have on the market is this 670G actually that works. But as you will see, we have many other things, new things. This is the Control IQ with tandem pump. Very nice results, recently published in the New England Journal of Medicine, as you can see, with a time in range of 71 in this generally well-controlled population. Under investigation, a tubeless Dexcom and Insulet algorithm, also 76 time in range overall. And the do-it-yourself community, as you know, they're engineers, they're extremely smart, and they can do a very good job. Of course, it's not for everybody, but those that can do it, they can do a very good job. This year on the virtual ADA, those that follows, actually, there was an NIH-funded study presented that has an acronym of FLAIR, and this is a publicly funded study with the newest technology, with this advanced hybrid closed loop. It was a randomized controlled trial, actually, that include, of course, CGM and also A1C. And it was actually 7 clinical sites, 4 in the United States, including the Harvard, Joslin, and Yale, 1 in Israel and 2 in Europe, 1 in Hanover and 1 in Ljubljana, which is my town. And actually, it was a very complex study. We also included people on MDI and people with really not optimal control, with an A1C above 10. And this is not the main outcome, because it's still confidential, because it's being submitted. But I just want to show you that the new advanced hybrid closed loop that gives also, this is the mean glucose, that gives also boluses, automatic boluses, is considerably better. And this actually is just to show you that if you use faster analogs, this system can work considerably better. This is the difference between an ultra-fast analog and the regular fast analog. So we have new hope even with the existing systems. And another one is coming. You're well aware of this new Urley that was also presented several times. And it's pramlintide, a very recent actually publication. Look, this is closed loop without pramlintide, and this is closed loop with co-formulation of pramlintide. So it's amazing actually how this addition can do the postprandial glucose and improve. This is actually no advanced bolus. This is just the closed loop, really nice job. And here, time in range without pramlintide, the normal 70 for closed loop. With pramlintide, 84% of time in range. So really, really amazing. For those that don't use technology as a closed loop, you use the same technology as an advisor. So it was shown that these advisors work exactly the same as the physician. This is the comparison between the physicians and the advisor. And advisor is actually kind of an expert, and then help physicians adjust the treatment, each and every dose, actually, to really improve the time in range. My predecessor discussed connected pens. This is the download from connected pens. As you can see, looks similar to the pump. This is the CGM. This is the connected pen boluses. And if you have an advisor, actually, you get advice on each dose.
We have only 1 more minute.
And this advisor was FDA approved and has a CE mark. So it's on the market and approved by the authorities. Targets we discussed, so it was very hard to reach them. Al Hirsch was the first to say that A1C basically isn't enough for people with diabetes, for individuals. We were able to put these guidelines together that were widely accepted by all and endorsed by all international societies. And again, time in range of 70, ranges between 70 and 180, and the hypoglycemia, very importantly, below 1 hour, below 4%, below 70, which must be less than 1% or 15 minutes below 54. And also, of course, the upper part is limited. So it should be below 6 hours, above 180. You know it already. And the AGP report, crucial, very crucial actually, for the common unified presentation of CGM data. Several publications are now coming up actually to understand the time in range should be discussed with time below range and maybe also with glucose variability. Finally, the COVID era, actually it was virtual. I know India is very good in virtual, so you probably did a very good job. Actually, the first person that I know in Europe was Professor Pratik Chowdhury, that there was at King College London, that most of you know very well. Is the leader in diabetes and a leading person in this. This is Thomas Dunn in Hanover, also started immediately. And this is us actually when we started to connect. This is Professor Bratina. We started this clinic and people on the Facebook actually were very happy. This is again Professor Bratina and a young person with diabetes doing the clinic. Time in range was crucial, one of the most important hashtag word actually during this COVID crisis. And did it work? There are several papers actually published. This is a nice paper demonstrating that those actually that stayed at home did even a better work with a CGM as those that had to go to the hospital. A very important guideline, actually kind of a position statement of an expert group, what to do during the diabetes, COVID diabetes era. And here, as you can see, glucose variability and CGM, either you are inside ICU or outside ICU is crucially important. A very nice paper from Tom Dane and Katharina Limberg in the Lancet Diabetes Endocrinology, why this online was so important. Also, please look if you want about the opportunities for research during COVID related to diabetes. Will Cephalou, the former editor of Diabetes Care and then president of the ADA, is now at the NIH, actually in the United States, and was supporting several projects on the COVID research related to diabetes. Let me propose a couple of conclusions to you. So more technology brings individuals closer to the time in range and time below range. CGM with connected pens are the initial step, particularly if you have advisors. And this may be of big interest for India because you will have connected pens and CGMs, and perhaps the missing link may be the advisor. And close loop for those that will have it actually brings you closest to these targets. And what potentially is the most important is that individuals with diabetes now really have actually choices, and these choices may reduce the burden of the disease. As already mentioned by Jyoti, actually join us in Paris. It is next year, February 17 to 20. I do believe we will meet live, face to face. So I'm looking forward to see you all. This is my team. They have to work while I speak. Thank you very, very much for your attention.
So thank you very much, Dr. Tade. Thank you very much for the brilliant oration. So I probably haven't missed any 83 except for one. So please stay back and we will move on to Dr. Parthaka. So Dr. Partha is a good friend of us, and he's the National Specialty Advisor, Diabetes with NHS England. He's a pioneer of the Super 6 diabetes model, which aims to deliver diabetes care differently, and is recognized as one of the good examples of integrated care. He's known as a very, very good and a prolific speaker. He writes a monthly blog for the BMJ. He's very active in Twitter. He's a known, he's known for his oration. He writes very well. He's a co-creator of TAD, Talking About Diabetes. And these are the TED Talks from those with type 1 diabetes. And he has also introduced the low carb app into the NHS apps library. So over to Tade Battling on the use of technology to increase the time in bridge. Please.
Okay. Thank you very much. So first of all, I'll start by just saying thank you to everybody for the kind invites and the lovely introduction. Thank you to Tadej as well for the lovely kind words you mentioned there. So obviously we are, as I say, we are following in the footsteps of you all and what you've achieved. So always very grateful for all the support and everything you have.
Dr. Partha, your voice is okay, but can you be very somewhat closer to the microphone?
I will. Is
much
it better? How's that?
Yeah, better. Much better, much better. Okay.
So I'll share my screen and we will start the. Let's see if you can see it. Can you see it? Is it now shared screen?
Perfect, perfect.
Excellent. So I was going to talk a little bit about type 1 diabetes, art of the possible, and where we are. So I think to begin with, I think if you take a step back, what will actually improve type 1 diabetes care? I mean, these are some of my personal belief. I think to improve it in a country, you need, I would say, to raise the profile of type 1 diabetes. I think that's fundamentally very important when you're looking at a overarching view, because the majority of work, quite understandably because of the size of the population, is in type 2 diabetes. So you have to raise the profile of type 1 diabetes, why it's important. And I personally believe type 1 diabetes is very much dependent on what you can offer people with their self-management and peer supports. All the technology and everything we talk about are actually tools of self-management. Then you need some sort of pathway, you need training and all that. So just to take that thing forward, the first thing, however, any country or anybody needs is data, because if you don't know what you're trying to correct, then you have a problem, because then you don't know where you're starting and what you need to do, so to speak. So in the UK, we are very fortunate and lucky that we have that data. And what the data tells you is that if you look at that, this is for all type 1 diabetes in the country, all 250,000 odd people, nearly 250,000 type 1 diabetes we have in the country, which is nothing compared to, for example, a big country like India. But at least we know where they are. And what we do know is that as a country, we are very good at checking their HbA1c, blood pressure, cholesterol, creatinine. We do all that very, very well. What we're not very well at is actually that. So HbA1c less than 58 or 7.5%, you can see that about nearly 30% of the population have got that HbA1c less than 7.5%, which means 70% isn't. Is that a good or a bad number? It depends as to what you're comparing it to, because in the States, if you look at the T1D exchange data, that value is actually around about the 15 or 18% mark. However, there are other countries, Scandinavian countries in particular, where much better evidence, much better data is available as well. So I think the first step is to see what do we know as a data set? What is it that we are getting right? Taking things forward, Jyoti just kindly mentioned some of the TAD things that we do and some of the comic books. And the importance of that is not to just do something fancy. I think the important point is to raise the profile, as I said. So these are means, and comic books are a very easy way of raising profile. We're in a world where Marvel Comics is very popular. You know, everybody, it's in the public consciousness. So that's one of the ways to try and sort of drive that. The reason for the TAD Talks was actually about showing that, you know, type 1 diabetes is not a barrier. So in our TAD Talks that we did, we had somebody who flies a Boeing. We have the Prime Minister of the country at type 1 diabetes. We have got James Norton, who has talked about being the next James Bond. The important bit there is that it was not a barrier, and this was about normalizing type 1 diabetes. It was just about showing that actually what you can do here is try and help people. And to also for these big guns or these big celebrities to come out and say what's needed for the type 1 diabetes. So it also helps in putting pressure on the system to try and improve things. We did a version of Language Matters, and the relevance of the Language Matters again goes back to the issue about raising profiles, because we talk about language, and as I'm sure you're very well aware, the words such as reversal of diabetes is very easily used. What it does do, and as important as the topic is, and I speak from a country which has led one of the pioneering studies, the direct study in the reversal or remission of type 2 diabetes. It's the study based on which the whole world has been looking at how to use or look at remission of type 2 diabetes. But when we have organizations or people using it as remission of diabetes, what is lost in that is the importance of type 1 diabetes, which, as I'm sure all of you know, cannot be reversed, can be put into remission. And it dilutes away the message that this is a very different pathology, which, as Tadej and others mentioned, has got a very important place where technology has got a huge role to play. It's a very different pathology, very different physiology, very different needs, and it's not possible to branch it all together. I've just briefly mentioned some of the work that has been done in India on the back of this, and Banshi Sabu, as ever, has been involved in this with his kind guidance as to what we have done. One of your next speakers is Jazz Sethi, who's also been, and I think it's worthwhile having a look at it because it talks about what I've just said, raising the profile, important about what we are saying about types, why different types are important, where technology fits in. Because if you take a step back, before we jump onto people getting access to technology, talking about time in range, you need to raise the awareness that people need the technology to even get to that stage. And then we have this, the self-management side of things. I think what we as healthcare professionals need to be very, very mindful. And this is where I personally have been a big fan of the Freestyle Libre or indeed any CGM, because for me, that just helps people navigate their type 1 diabetes better. We as healthcare professionals can only provide them so much time. The rest of it, they live with their diabetes, so why not give them options to look after themselves better? This is the 21st century after all. And, you know, self-management, for example, education programs, why should we all have to do that face-to-face? Today's world of COVID-19 has opened up the possibility of looking into different areas of doing it, and thereby we've got digital platforms. So in the UK, we have just recently launched national platforms. We have said, you know, if you're going to provide education, do it digitally. Why not? People are busy. People are worried about traveling because of COVID. So let's not stop everything. Let's give them the opportunity to learn and be educated and learn from each other online. And Libre is a good example, as I mentioned. So that's the important bit of self-management. What about peer support? I think the fundamental of peer support is you are not alone, and goes back to the concept we talked about, time in range. I'll briefly touch upon it in a minute. But I think when you're talking about people who are in technology, one of the best benefits they get is not from actually a fellow healthcare professional. They get it from colleagues or peer who are doing the same thing, living with their same lives, making those changes, knows the impact of, I don't know, alcohol, time of the month, weather, little nuances which people living with type 1 diabetes will have better knowledge of than those who might have read it from a book like ourselves as healthcare professionals. More time to exchange ideas. Healthcare professionals need to be guides, and I think that is where we sit. That's my fundamental belief in a national role I do, that our role needs to devolve to being guides. Time in range, technology, all of them are just tools that we try and edge people towards so that they can use it. Social media, group events, and let people bond and challenge the status quo as to what they're doing. Now, what we did in the UK, and Tadej again briefly mentioned about Pratik, who's a very good friend of mine, doing some great work, and me and Pratik worked together to create a pathway. The relevance of this was trying to look at all the evidence. Again, this is all in the public domain, so you can look at it. It was just to guide people to say who would benefit from what technology. There's so many others, flash glucose or intermittent CGM. There is the actual CGM like Dexcom. You have pumps coming through, and we've got closed loops, which we'll talk about in a minute. So this was more about trying to give people a bit of guidance, and the great and the good of UK, at least, in type 1 diabetes world, came up with this particular suggestion as to whether this would work or not. What about training? I've just given you a simple example. I don't want to spend too much time on this, but this is a simple poster that one of the it hasn't come through very nicely on this particular slide. But this was about showing that, if you give people the Freestyle Libre, just echoing what Tadej said, you need to take away the healthcare professionals from the patients. You give them the tool, you give them some simple basic support educationally, which in this case of this particular team from Guildford was an evening of education they gave, and they have achieved the best result in the country as far as improving HbA1c goes. You give people the self-management tool, you give them the education they need, and you give them access to a healthcare professional when they need it, which is what this team did. And funnily enough, their improvement in HbA1c was quite astounding to watch. What about training? I think it's important about training. And when we talk about time in range, we are sometimes guilty of being in our own bubble. So not everyone knows about type 1 diabetes. And I include specialists in that. I think the belief that all endocrinologists know very well about all the nuances of type 1 diabetes is not right. I think if you're a specialist, one thing would be quite good to do is help cascade knowledge to our other colleagues in primary care, so the right person comes to you. So you're not sort of thinking of everybody as diabetes as one overarching umbrella and thereby just giving them one treatment. So you know that people with type 1 diabetes can get to you as a specialist so they can get access to the right technology and thereby time in range, etc. Advocate for people with type 1 diabetes, and as I mentioned, language and the ethos of reversal. So as part of this, one of the things that we have been working on from the UK, along with colleagues in India, is to see whether we can build a training program or something that will appeal a lot to people who are more in general practice. And it's not about trying to teach them the nuances of technology, more about saying this person would benefit from a technology. Look at the evidence, look at what we can achieve if you gave them technology. I'm going to give you a couple of examples of what we are also doing and this is the important bit, which I believe, and this is what we're doing in the UK, where we look at all the hospitals in the country. And the reason I show you that is not this slide, but this one. This is all the hospitals in the UK. And if you believe for a second that everybody in the UK who's in a hospital gets the same level of care just because they're under a specialist and thereby having access to pumps, you can see the problem. This is the percentage of people who have got access to pumps in their particular clinics. And you can see the wide range that is there, the huge difference across the country. And this is in a first world country such as the UK. Pumps are not bound by any funding problems in this country. Pumps are one of the few technologies in the UK which doesn't have a funding issue. But yet there are people, and I have personally been to places where specialists will say that they're not still convinced by the benefits of pumps, which is not acceptable in 2020. So disruptive innovation, which is one of the focuses of the areas I wanted to talk about, and I've just given these particular areas, closed loops, and I think the next speaker, Jazz, said he's going to talk about closed loops and DIY. But this is what I call patient-led revolution. So the holy grail or the dream obviously is not to have type 1 diabetes, find a cure. And all people with type 1 diabetes will tell you about the 10 years cure that's forever been coming, but never quite, has always been 10 years away. The next best option we have is people have gone out and created their own algorithms, created their own DIY or do-it-yourself technology, trying to bind the pump with the CGM or the continuous glucose monitor, and thereby trying to improve their care. They've got algorithms, and now what we have in the UK, we have got Professor Roman Hovorka, who's come out with also another algorithm. But this is where the concept of time in range comes in, and I particularly am a big fan of, because what it does do, it does fundamentally change the dialogue between patients and healthcare professionals. And the example of that being simply is that it's very easy to say, sitting behind a desk to somebody, what you need to do is get to an HbA1c of 7%. It's a slightly different debate when you're saying that what we're trying to do is get your time in range to 60 or 70%, with the acceptance that a fair percentage of it will be outside that range. It's a different type of debate where you're saying that we're not trying to get your range always between 4 and 10 or 72 and 180 all the time. Because that's a big belief. If you go and ask a lot of your patients as to what they feel, healthcare professionals telling them it's about trying to get the blood glucose in range all the time. That's actually not what any evidence will tell you. And that's what the time in range concept is very good about, to say that it's not about 100%, it's less than that. Less than that will get you good control, which is what all the study and evidence base has shown. So to me, the key to some of that is probably all of you as healthcare professionals, about engaging. It's about giving people the tools. Time in range comes with education, comes with support. And from what we have seen in the UK, from our nationwide experience, is that people's time in range has improved once you give them the self-management tools, once you engage them with peer support, once you try and talk to them about the relevance of not trying to be in range all the time. And an acceptance that sometimes it's impossible. Sometimes there'll be days when it goes outside and not to be judged because you felt that they didn't quite do well while you weren't quite aware of their own conditions and what life they were having. So raise the issue and challenge the system, as I say. And somebody mentioned about industry, I think, in one of the talks. And I think this is a very fundamental part that we should not forget to address. It is not just a responsibility of healthcare professionals and patients to fight for access. it's also the responsibility of industry to do the same. There's no point in just saying here is something, a kit, and you all need to go and buy it. In economically challenged countries, and now with COVID-19 economic downturn, it'll become even harder. So industry needs to do its part to try and engage with all people concerned and to see what they can offer to try and get more people on such systems which will benefit people. And I will finish with this because I think it's quite important. I think this quote is not about what we deserve, it's about what we believe. So I've been very fortunate to work with a lot of colleagues in India, and I've always been, as Tadej mentioned, been blown over by the desire amongst lots of professionals, Banshi, Jyothidev, everybody, to try and improve type 1 diabetes care. And I can't see any reason why that can't be done, and it doesn't have to be niched in any particular centers. So hopefully this talk does help. It does give a bit of guidance as to our policy, what we're filling 4 or 5 planks of, as I said, raising the awareness, trying to make sure that you focus on self-management, challenging industry, and then making sure your primary care colleagues can refer you the patients who will benefit from, rather than being told, here you go, just have 1 insulin a day and carry on. I'll finish with that. Thank you.
That was simply fabulous, my dear Partha. It is very good. And this is actually a journey from the past. We started with ordinary meters, and then today talk about time in range, and then you spoke about the emerging technologies, the difficulties in reaching time in range, the COVID crisis. We all touched upon COVID crisis because times are changing.
Yeah.
And now the next speaker is going to be our Jazz. So why I said Jazz? Jazz is now very, very famous all over the country and even outside the country. She was diagnosed of type 1 diabetes at a very young age of 13 years, and she has survived. And now she is living with diabetes, and she has dedicated her life for those with diabetes, those children and adolescents with type 1 diabetes. And she has established her own society, that is, he is the founder and director of the Diabetes Foundation, which I know is closely working with Dr. Parthaka, Dr. Benshi. I am also associated with this foundation, a global movement to make those with type 1 diabetes feel heard, understood, supported, and celebrated. And she's working closely with all the scientific organizations such as Diabetes India, RSSDI, and the NHS Foundation in the UK. She herself is a certified diabetes educator, but I know her as a professional dancer, and that is how she is propagating the messages to the community of type 1 diabetes. And her mantra is very, very simple: live happily and bolus regularly. I am a fan of Jazz, and we are eagerly waiting for the experience sharing, and that is on the journey forward. She is already on a closed loop system.
Thank
So
you.
please
Thank you
share
so
the
much, Dr.
experiences.
Jyoti, for inviting. Firstly, missing the waves of Kerala, but hopefully that will happen soon. But thank you so much. I'm just going to share my screen. Right. So a lot of talk has been done about technology and how technology can help in management of type 1 diabetes. And I thought I will give a lived experience of that. So I have been type 1 diabetic for 11 years now. I was diagnosed when I was 13. And I'm just going to share my journey of my treatment sort of evolving through the years and how the APS closed loop system has made an impact on my life. So life with type 1 diabetes is not easy at all. It's not a piece of cake. There's a lot of monitoring. There's a lot of calculations, a lot of pricks in a day. And this is how my treatment started as well. I was on basal bolus injections, and I used to do SMBG 6-7 times a day. And I had fluctuating sugars, to say the least. And then this was sort of made easier when I was introduced to the insulin pump and the continuous glucose monitor. I got onto the Omnipod in 2014, and I got onto the Dexcom G6 2 years ago. And they definitely made life easier, no doubt about it. But I still had fluctuating sugar. So there was insulin delivery with different basal programs throughout the day. And I was seeing my sugars in real time, but I still had fluctuating sugars. And why this was because there was no intelligent real-time insulin adjustments. the pump was not able to keep up with my timetable, because my timetable was very different. As Dr. Jyoti said, I'm a dancer, so certain days had lots of rehearsal, certain days had no rehearsal, and my basal programs were set, but my timetable was not set. So there was a clash in those. Of course, then this was made easier when I was introduced to DIY Loop, the artificial pancreas system. And I do have to actually credit Dr. Parthakar for this, for sort of introducing me to certain people in the UK who helped me set it up. So thank you for that. And I'm going to be sharing my journey with Omnipod APS, with the Loop and the Riley link. This is completely on personal experience over here, and I'm just going to share with you my experiences. So the components, very briefly, for my APS system are the Omnipod, which is my pump, the Dexcom G6, which is my CGM, and the Riley link, this little guy over here, which is my device, which sort of communicates and sort of hacks into the pump and the CGM and makes them talk to each other. And that's when the magic actually happens. That I had the pump and I had the CGM, and they were two separate identities. But when they started talking to each other, that's when the magic happened. So this is what my system looks like. That's my Dexcom, that's my Omni, that's my Riley link, and on the phone, you have the Loop app. So this is what my APS system looks like on my body with my iPhone and app. The process, how I set it up, was basically with the Loop, you have to build your own app. It is DIY and it's very true to its nature, do it yourself. So you have to download Xcode and you have to do a little bit of coding in. It's not as easy, but it's not rocket science as well. The beauty of this is because of the community, there's amazing documentation done about how you can build it. So GitHub, for example, has the entire process, the entire journey. Certain things you have to just copy paste, and it just does it for you. And once you're done with the process of building the app, it comes onto your phone, it comes onto your watch, and then you have to configure the settings. And the settings that you configure are your ISF, your ICR, your suspend threshold, at what level of your sugar do you want the insulin to stop, override settings, which I personally use a lot because it sort of makes you get a new range when you're exercising. So I have a dance override. So when I'm dancing, I want my sugars to be slightly higher. So if my normal is 90 to 100, when I'm dancing, it's about 120 to 130. So just to completely avoid hypos. And of course, you enter your target range. So once you set in these settings and you press OK, the magic begins. And the magic begins almost instantaneously. The basal rates adjust every time it loops, depending on your sugars, automatically. And it's absolutely magnificent the way this happens. So if I can show you a screenshot of my basal, my insulin history, as you can see here, my normal basal rate for this particular time duration is 1.75 units per hour. But as you can see over here, depending on my sugars, the temporary basal has kicked in. So at certain times, it's completely suspended, it's back to normal, it's increased slightly, increased a little bit more further. So even if I'm, let's say, not bolused correctly, I've not counted my carbs correctly because I'm terrible at carb counting, to be honest, my basal rate sort of helped me and adjust a little bit for me. So it definitely, the word used, burden of diabetes, it decreases that for sure. And just like type 1 diabetes, it is constant. It automatically adjusts the basal rate every time the green loops. As you can see over here, this is the active insulin graph. So you can see this is during the nighttime, how the basal has sort of just gone up and down, and it's ensuring smooth sailing sugars. You still have to bolus for your meals. You bolus from the app in your phone. So if you can see the spike over here, this is when I bolus for a meal. And on the corner over here is your IOB, which is your insulin on board. So you know how much insulin is still in your system. This is what a little bit more of the graph looks like. The dotted lines are values, which it takes from your CGM. And the dashed lines are predicted values, what it predicts for you. So if I share my dashboard over here, the green loop, that means that it's working, it's in communication, it's in range. The 128 you see here is taken directly from the Dexcom. This +0, this is my basal setting right here. So +00 means that it is at the basal that I have set it at, which is 1.75. If it decreases and increases, it means the basal is adjusting. And this is my pod health. So it starts correcting whenever it feels it needs to correct. The impact. I used to suffer from a lot of hypos in a day, way too many hypos. And the first impact is minimal hypos. I have seen my hypos go down drastically. If I used to get, let's say, 5 hypos a day, I now get maybe 3 or 4 hypos in a week. Decreased severity of hypo. And this is something I really want to point out. Earlier, my hypos used to go as low as 35, 40, really bad ones. I used to lose my sensitivity to them as well. Now, even if I do get a hypo, it sort of cuts off at 70 or 75. So now my sensation and my symptoms are also back. What I earlier used to feel only at 50, now I'm feeling at 80 or 70 as well. And of course, as everyone, the previous doctors have also said, a greater time in range. My time in range, what I checked on my Clarity app last week was 88% in my last week. So when your time in range, your general mood is better, your general feel is better, you just feel better emotionally, physically. So it just makes life a lot easier. Quality of life, better sleep, no nocturnal hypos. I used to get a lot of I have passed out from a hypo earlier on, and I was extremely scared of passing out again. But with this, my mind is at peace. My parents' mind is at peace as well. They don't have to worry too much about me. Much less fluctuations, has reduced the burden of diabetes. And like I said, the APS keeps up with my timetable. So if normally I was having breakfast every day at 8 because I knew that my basal at 8 o'clock would, increase. Now, even if I wake up at 10, it's a Sunday, I wake up at 11, I will not fall into hypo. It will correct for me. It will suspend my insulin. So yes, now I'm going to show you a few graphs of what my sugars were before. I used to randomly take screenshots, and this is just on a varied different days completely. But as you can see, I was not the ideal candidate, and this was just my normal life. Unfortunately, it was not always like this, but yes, this was on a day-to-day basis where my sugars were all over the place. If you can see this graph over here, I was time in range sometimes, but again, they were not like a linear graph, all over the place, peaks and mountains and whatnot. And now I'm going to show you a few graphs of after I started looping. And as you can see, I just love it. It's like a work of art, I feel, genuinely. It's absolutely beautiful, completely linear, in range, and it reflects in my quality of life as well. The next graph I'm going to show you is on the day I began looping. The day I set it up, I had terrible sugars. The moment I started looping, within half an hour, I could see a change in my graph. So this is how it was on the day I began looping. Over here somewhere at around 11 p.m., I started my loop. And as you can see, I started getting into range over here. So for me, to wrap up, the pros, very easily technological marvel, no doubt about it. Bolus from phone or watch. So the convenience of it is very, very high. I could just bolus from my phone. Basal modification, of course, a greater time in range. The override settings, especially for a dancer or for anyone who is involved in a lot of activities, it's really helped me. It adapts rapidly since it's a patient revolution. Since I started looping, I've already updated it twice because 2 new updates have come. So it's the way you update your phone. It just comes to your phone the same way you just get onto the site and you update it on your Xcode. It's by the patient. So there's definitely a user in the design process. It's user-centric. And there's also an open loop option, which means that if you're a little hesitant initially, what it does is every time it wants to make a decision for you, it'll first ask you. It'll first ask you and say that, okay, I'm going to make this change. Is it okay or not? And then you say yes or no. I did not use this option. I was very much into it. I trusted the process completely. So I went with closed loop directly. But yes, a lot of my people I've talked to do the open loop option first. The data, I'm not going to get into this. You all probably know it. But this was by Dana Lewis. And the mean blood glucose and time in range improved in every time category. So the data speaks what I'm speaking. Of course, a few cons. DIY means do it yourself, means build your own app. If you are hesitant towards technology, I would recommend asking a friend or someone to help you out. It's not rocket science, but yes, it requires a little bit meticulous coding and stuff. It's not FDA approved yet, but I know it's coming out. Horizon and stuff is coming. So whoever has a problem with that, I can understand. It's not a cure. So very often we understand, even when you're on pumps, you think it's a cure, but you still have to bolus, you still have to take a little care. Tech trouble at times. Once it happened with me that all my settings vanished from the loop and I completely freaked out. But just It takes a little time, you get back to it, you get used to it. Red loop at times, which means that if your phone, your Riley link, and your pump are not in the same vicinity, instead of the green loop, it comes as a red loop. So you have to just make sure that your Riley link is with you at all times. And finally, there's no helpline as such. So there is also a great social media group. And sometimes when I have a tech trouble, I just type it in and I get a response. There are lots of compatibility options. I'm not going to get into this, but the older Medtronic pumps can compare. There's also an open APS and an Android APS, which I don't know much about, so I'm not going to speak about it. I do know that Loop is only for the iOS, but there are these options for different phones and devices. So yeah, to sum it up, the Loop does not sleep so that people with diabetes can. And this is a part of the We Are Not Waiting movement. It has completely changed my life. And if it was available for everyone, I think this is the future of type 1 diabetes. Thank you. Thank you so much.
Very good, very good. So the take-home message for those at home is our jazz is having a new life, and it has tremendously improved your quality of life. There is little or no hypos, and there are no mood swings. You are more active, and now your work as a diabetes advocate, as an ambassador, is much more exciting when compared to the previous years.
Absolutely.
And congratulations. But I understand that this is not approved. This is probably not unethical, but this is not approved. But this is a result of those frustrated communities. So they have come up with their own devices, their own algorithms, and they have created the DIY artificial pancreas. So we have only 3 to 4 minutes left for questions. So I have a question to Dr. Tade Batilno, and this is on measuring the accuracy. Because of course this question is on glucose meters, but I know that you are an authority on this. How reliable is MARD, mean absolute relative difference, comparing the accuracy of glucose meters? MARD have been actively discussed for CGMs, but few papers have been published for glucometer comparisons. So probably the question is on the Clark, and so would you like to answer this question? Because you are an authority on this. Please unmute and
yeah, thank you very much for this question. So basically, there is a paper published on SMBG meters available in the United States. And it was quite obvious that most of them do not meet actually the FDA requirement. So the accuracy for most actually was beyond this. And the reason is that, you know, when they put those strips for testing, they use better lots. But when you take a lot out in, you know, in a pharmacy or in a drugstore, actually, those lots are not comparable. And this is what the study did. So they took over-the-counter strips and realized that many actually don't meet criteria. So the question on CGM accuracy, actually, it's well known, it's a time delay. But then if you actually understand this, they are, to me, surprisingly accurate. Many now report marks around 10. And yes, in addition, they have the trend arrows. And this, of course, is what really makes the difference. So you can actually predict what's happening. So I'm not so much on the accuracy anymore. I'm on the fact that they basically tell you what will happen, which is exactly where you need to react. So if you take together the measurement and the trend arrow, actually, you are considerably better off as compared to SMBG. This is how I look on the accuracy. And of course, they become more and more accurate because, you know, the technology of making those sensors is improving.
Thank you, thank you. Jazz, there is a question for you. How many times do you adjust the basal rate in a day? So it's automatic, right?
Yeah, for me, my basal presets is there's one basal in the night and then 2 basals in the day, what I've set it at. But my loop is constantly changing it. So I don't know how many times it does it, but lots of times.
Lots of times. Hundreds and thousands of times. You have something to say, Dr. Tade? Tade is appreciating.
It was just a thumbs up, you know, for Jazz.
Yeah.
Really, so I'm really impressed.
Thank you.
So do you have such patients there in Ljubljana who are using the loop or the Android APS or the DIY?
we have a family where the father is an IT engineer. So it's a very privileged family. And yes, they do very well, and almost as well as Jazz. But then, you know, I think you need a lot of knowledge to do it. So I can trust him, but I would be afraid for many. So this is the situation.
Okay, so it's time for us to conclude. So I would like to thank all the speakers, Dr. Tadej Batilo. Of course, we'll be meeting very soon in Paris. So we are all praying to the God that we can come to Paris for the next JTJD. So it might happen. So thanks to Jazz, our yeah, Partha is there. I was looking for you. I thought you are busy and you are gone. So thank you so much. And Benshi, you know, is multitasking. So he's, I think, lecturing in some other program. So in another webinar now. So that is why I have taken up the duty as a moderator. So Partha, one last question to you, because I thought you are busy somewhere in the clinic. So Jazz was just discussing about looping. So it's a curiosity, because I understood that you are the one who has advised her. Is it so common in the United Kingdom?
It's not. So I think so here is the thing. I personally believe that artificial pancreas or looped technology is the way ahead for type 1 diabetes, right? I think industry is now moving to do that. So if you look at the offerings that are coming from Medtronic, or let's say coming from Omnipod, or well, any one of them, they're all, you know, the T-Slim, they're all coming up to it. So looping, or the artificial one that Jazz is using, is the one that is patient-made, and that's been driven by the fact that the industry haven't moved quick enough. I suspect when industry come online with more approved means of doing it, you know, that's what we will encourage. So I think as clinicians, which Tadej will probably say the same thing, we just want to give patients access to the right thing, you know. That's my view. And so that's what she's got, and it's clearly helping her. So the more you get closed loops, and I think for me, what it has done as a community, it's pushed industry to adapt. And and that's what you need. That's what you need patients to do. We have clearly not been able to do so. So patients can do it better, even better.
Yes, we are all excited. So thank you so much. Thank you so much for your precious time.
Thank you for inviting us. Thank you.
Thank you. Thank you. Thank you.
Thank you, everyone. That was a very enlightening symposium. For the next session, I would like to invite the chair, Dr. Balakrishnan Valiyor. He's a professor of medicine and head of Center of Medical Research and Non-Communicable Diseases, Government Medical College, Kannur. Over to you, sir.
It's a privilege and pleasure for me to be a part of this most popular academic event in Kerala. Let me thank Dr. Jyothidev and his team for inviting me to chair this session.
So your voice is not, you have to unmute. Yes.
Dr. Jyothidev has proved that COVID cannot take away any academic spirits, or it cannot spoil a spirit, and he have innovatively introducing a new technology. I think this is the best mega digital conference in Kerala for the first time. So I would like to congratulate Dr. Jyothidev and his team for this program. And again, there is an unprecedented increase in the number of type 2 diabetes, as well as the increased lifespan of the people has led into a large, great number of elderly diabetic population. And there are some many unique issues, especially to these elderly people. I don't go into any of this. Our eminent speaker will be deliberating on this issue. But polypharmacy, and again, cognitive issues, and again, availability of care and support and all this, and in amid of this COVID-19, and they are not even getting a proper care now. There is no caretakers in any of the center, and this elderly population is a unique class of people who need a special care and treatment. And today we have got a very fortunate to have Dr. Anant Moses, a great academician and a very popular diabetologist, and who will be deliberating this topic to us. And it's customary to introduce Dr. Anant Moses. And is happy to introduce Dr. Anant Moses. He's an MD and FRCP, and he's holder the most prestigious FICP, and is also member of the RSSD and fellow of RSSD, and he has got a FRSSDA. And he was the emeritus professor of MGR Medical University, and he was the former director and HOD of Institute of Diabetology at Madras Medical College. And he was the organizing secretary of RSSD 2012. And he was again the chairman of Tamil Nadu chapter of Diabetology, and easy member of National RSSD. And he was the former Senate member of MGR Medical University. He has got more than, when I went into his biodata in the net, and I think I seen that a large number of publications and very large number of presentation. I think he's the right person who can talk in detail, or we can tell us all what are the unique issues and problem and how we will manage the diabetes in the early population. So over to you, sir.
Thank you. Good evening, sir, and thank you for the kind introduction. And thank you, Jyothidev, for having invited me for the program. I'll share my screen now. Is it visible?
It will come.
Not yet. Not yet. It will come.
It will come.
Yeah, now it is coming.
It's coming, but I'm not able to see the screen.
No. The PowerPoint hasn't come.
No.
Some problem. There is some issue.
It's come now?
Yes.
Can you see my presentation?
Yes, I can see.
Yeah, now it is okay.
It's okay, right. Okay. Thank you, Jyothidev, again. I think from one end of the spectrum of type 1 diabetes in the young, we move to the other end of the spectrum now, managing type 2 diabetes, diabetes in the elderly as such. And as the chairman rightly said, this is a time during the time of COVID, we really feel that need for the real challenge in managing elderly diabetics at home. So actually diabetes in the elderly includes two groups actually. That is survivors of young and middle-age onset diabetes. People who get diabetes at around 30, 40, they become old and they are diabetes in the elderly. And the second group of people who develop diabetes above the age of 60 or 65, that is diabetes in the older age, usually type 2 diabetes. Very rarely we can have type 1 diabetes as an autoimmune diabetes, rarely in the elderly, but that is very rare. So we'll just discuss about the first two types of diabetes. Before that, what is elderly is a big question. WHO says it's above 65. UN said it's 60 plus. And in India, I think senior citizens above 60, everyone is a senior citizen. Rather, we don't use the word elderly, but we are senior citizens. And there is something other classification of the young old is up to 75 years, 65 to 75. Old is up to 85. Very old is only above 85. So our patients will fall into all these categories. So there are certain myths in the about diabetes in the elderly. Many people think there is a high prevalence of diabetes in the older adult is inevitable, but it's not so. Hyperglycemia in older adults is usually a benign condition. I think that is again a very wrong idea, because I told you there are two different types of diabetes. People getting diabetes at the age of 40, with 20 years of diabetes, they become 60. It's not a benign condition. And reduced life expectancy makes the consequences of uncontrolled diabetes irrelevant. That is also a myth. The people elderly people who already have comorbidities, they may develop diabetes and the comorbidities may increase. So aging and diabetes, poor diabetes control exacerbates the aging process, and it causes age-related disease to develop earlier and makes comorbid condition worse and hard to manage. What are some of the peculiarities of diabetes in the elderly? Older adults with diabetes are at risk of developing similar macrovascular and microvascular complications as their younger counterparts. This we should remember, because we all know age itself is a risk factor for many of the macrovascular complications. Without even having diabetes, you can be a high risk for cardiovascular disease or a cerebrovascular disease. So when diabetes adds to the old age, I think the risk is more. We should not underestimate the risk of macrovascular, particularly macrovascular complications in elderly diabetes. However, the absolute risk for cardiovascular disease is much higher than in younger adults for the simple reason age itself is a risk factor. Elderly adults with diabetes suffer excess morbidity and mortality compared with elderly individuals without diabetes. That is again well known. We'll just rapidly go through some of these points in epidemiology, pathophysiology, clinical profile and treatment. Looking at the global prevalence, worldwide, the prevalence of diabetes will double. We all know that, with the greatest increase in the elderly population. Majority of patients with diabetes are over 60 years throughout the world, and very soon in India also. 20 to 30% of patients over the age of 65 have diabetes. You know, the prevalence of diabetes above the age of 30 in India is varies from 8% to 15% depending on the region you screen. But as age advances, the prevalence also increases. Elderly population is growing at a challenging rate in India. We all know it's going at a steady rate. Of all the diseases, type 2 diabetes is the single most disease affecting a large number of elderly population. And some of the survey done in India show the prevalence rate of type 2 diabetes in the elderly population to be around 30%. In the younger population, it's around 10 to 15%. And southern part of India, it is more, around 15%. I think Kerala has got a higher prevalence rate of type 2 diabetes. And if you go by age, almost 1/3 of the elderly population in our country have some form of impaired glucose tolerance or type 2 diabetes. This is changes in the blood sugar levels with age. These are done in non-diabetic individuals. Just to show you that as we age, the insulin resistance also increases. And as we go about 50, 60, the postprandial blood glucose level rises, which is a marker of insulin resistance, whereas the fasting blood sugar remains normal. This is even in a non-diabetic patient population, just to show you that rising age itself is a risk factor for postprandial blood glucose rise. What about IGT? It occurs inappropriately. 25% of older adults increases the IGT, we all know, is a forerunner of diabetes. And when diabetes is high, IGT is also high. Number of studies have shown that. I'm not going into details of the study. Now let us look at the pathogenesis of hyperglycemia in the elderly. The most common reason is insulin resistance. There is sarcopenia in the elderly, reduced muscle mass, increased adipose tissue, decreased physical activity, medications, coexisting illness, genetics, and finally, as we age, as insulin the beta cell also becomes old, the insulin secretion gradually decreases in the beta cell, and all this contributes to hyperglycemia in the elderly. Most important thing in the elderly is the function. We all know as we grow old, our cognitive function decreases even in a non-diabetic. But if you look at a diabetic patient, it is associated with a 1.5 to 2.5 fold increase in the risk of dementia in the elderly. This could probably be due to the microvascular disease in the brain, but it's definitely been shown in a number of studies. So severe hypoglycemia can result in permanent neurological damage, and which may accelerate the process of dementia. Again, this is important. Even small incidents of hypoglycemia can be harmful in the elderly. And sometimes hypoglycemia may masquerade as acute neurological symptoms also. That I think people who have worked in medical colleges are very familiar with this. People presenting as hemiplegia and others, and just when the sugar is controlled, it becomes normal. So severe hypoglycemia is dangerous in the elderly, and cognitive function also is impaired. There is something called a type 3 diabetes in the classification of diabetes. This in a few years, this has been recognized that type 3 diabetes is a term proposed for syndrome of diabetes and Alzheimer's disease. So there is a connection with Alzheimer's disease and type 2 diabetes. This is to differentiate it. We call it as type 3 diabetes. It has been discovered that insulin resistance can occur in the brain as well, and this may affect the brain cell function, and Alzheimer's disease may be precipitated. This is an important thing to recognize. This theory is supported by preclinical and clinical evidence, which suggests that Alzheimer's disease is a neuroendocrine disease. It's not purely a neurological disorder. And there are some possible specific therapeutic, though these are not cure or anything, they have shown that people who have been on statins, glitazones, and DPP-4 inhibitors and GLP-1 analogs for a long time have lesser Alzheimer's disease. Probably this may have some implication in the treatment of Alzheimer's disease. So what are the principles of treatment on the elderly? Basically, it is the same, but you have to control the hyperglycemia, and probably most important thing you have to keep in mind is to improve the quality of life in the elderly, and achieving the best possible HbA1c without producing hypoglycemia. I think this has to be repeatedly told. The most dangerous thing the elderly population, when particularly elderly population are living alone, is hypoglycemia. So you must know what target of blood sugar you keep, particularly for the elderly. Significance of hypoglycemia, I will not go into full details of this for want of time. This can lead to impaired cognitive function. It may cause neuroglycopenic symptoms or more. See, normally the protective symptom for all of us in hypoglycemia is adrenergic symptoms. Immediately we go take some food and we overcome it. The elderly people do not have blunting of the adrenergic symptoms and due to autonomic neuropathy, and this can cause dangerous hypoglycemia without warning. This is important. So this can symptoms can be missed, as I told you, as a hemiplegia and other things. So choosing the right drug and choosing the right target in the elderly is the key to success. Cardiovascular risk is a special concern. As I told you, age is itself an important risk for coronary artery disease. When you add diabetes to the age, it becomes an increased risk. So all the treatment which you are giving for a non-diabetic person should also be aggressively followed in a diabetic population. There are certain geriatric syndromes associated which can aggravate the diabetes. One is depression, particularly common in the elderly. And as our chairperson said, polypharmacy is an important thing, particularly in elderly. They'll be seeing about 3 or 4 specialists, and at least 2 or 3 drugs from each specialist will add up to 10 tablets each 3 times a day. I've seen some people 10 to 15 tablets 3 times a day. We do not know the drug interaction with these drugs. Some drugs cause drowsiness and so many other things. So whenever you evaluate an elderly person, please look into the polypharmacy, which is very important. And falls are very common, and certain drugs may aggravate it, like hypoglycemia, chronic pain, urinary incontinence, cognitive impairment. All this adds to the distress in diabetes. So the goals of therapy is not to use intensive regimen. Even minor hypoglycemia can be harmful. So the ADA standard gives clear-cut guidelines. Hypoglycemia should be avoided. Glycemic goals for some adults may be reasonably relaxed. I think this is very important. When we study, we always go by the golden marker, that is 7% HbA1c, 7% HbA1c, and for younger people we say 6.5. We always fail to think about the elderly, where the HbA1c targets has to be relaxed in many circumstances. And screening for complications like cardiovascular disease is important. This is the ADA standard of guidelines. It's very simple. For a healthy elderly, you can aim for a HbA1c of around 7.5 with multiple.
2 minutes left, sir.
Yes, or 2 minutes only. It's okay, right? If you look at the guidelines, I think these are all given in books. I will not go through it. It's very simple that for the elderly, you relax the HbA1c by 1 or 2. And for the very elderly with a lot of comorbidities, you can go up to even 8.5, and a fasting sugar of up to 150, and a 2 for postprandial up to 250 is even 300 is allowed in people with excess comorbidities. So don't worry about very high blood sugars and very low blood sugars. Keep them in between. So diet, I will not go into. Physical activity, you have to be very careful when you recommend. Cardiac evaluation is important. Foot examination is important. Peripheral neuropathy is important. But they also should be active. Otherwise, sarcopenia, which is always there, will be aggravated. Polypharmacy, we always talked about. What about drugs? Metformin is a safe drug in the elderly. It can be used, except you have to monitor the renal function. And sulfonylureas as much as possible. Try to avoid. Even the new sulfonylureas can cause dangerous hypoglycemia, because there are better drugs. Very short-acting drugs like meglitinides can be used. Thiazolidones are again avoided because it can cause water retention, can aggravate cardiac failure, particularly in the elderly, and it can also cause there is an increased risk of fractures when you use thiazolidones, particularly in the elderly. Incretin enhancers are a wonderful drug. 4 inhibitors have been shown to be very safe when used as monotherapy or with metformin. It rarely causes hypoglycemia, and that should be the oral drug of choice in the elderly. SGLT2 inhibitors are good in the elderly, but certain side effects you have to keep in mind. One is particularly elderly women with repeated urinary infection, and people who are dehydrated and other things. Otherwise, it could be a drug in elderly, but a careful monitoring is necessary. AGIs can be used again, but risk of only the side effects of GI intolerance is there. Insulin therapy remains the most versatile option. We have wonderful insulin. So many people have been talking about good basal insulins, good analogs, which can be used safely in the elderly with minimal risk of hypoglycemia. So in conclusion, I would like to say diabetes in the elderly now can be managed better due to the available multiple options like the new oral drugs, the newer insulins. It's essential to choose the treatment goal appropriately. The foremost aim is to avoid hypoglycemia. Don't be very aggressive in your treatment. The ADA gives beautiful guidelines for the elderly. We always talk about guidelines in the young. People also should read the guidelines in the elderly, where your strictness can be relaxed depending on the comorbidities. So the physician needs to underscore the importance of shared healthcare approach involving counselors, community workers, local doctors, specialist geriatrics, diabetologists are critical for ensuring good health of these patients. And as the chairman rightly said, these are period of COVID where elderly needs special attention. Younger people always get attention. There are a lot of elderly people in our country living alone. So these diabetic patients should receive special care. Thank you, sir. Thank you for the patience.
Thank you very much, sir, for chairing the next session. I would like to invite Dr. Mohan T. Shenoy. He's the Assistant Professor of Department of Endocrinology at Sri Gogula Medical College and also GG Hospital, Thiruvananthapuram. Over to you, sir.
Yeah, warm welcome to everybody. Am I audible?
Yes, sir.
Yes.
Yeah, thank you first, Dr. Jyothidev, sir, for giving me the opportunity to be part of this wonderful program. Being a virtual program, we are enjoying at the confines of our home thanks to COVID. So this topic given today in the first day is insomnia and diabetes mellitus. As you know, type 2 diabetes and sleep disorders are common problems which are coexisting. Type 1 also can have fluctuating glucose control, and it is also detrimental for the health. In general, the quality of life, the mood, all these disorders can also cause high risk of metabolic disorders, just like type 2 diabetes does. To discuss this topic of insomnia in diabetes, we have got a very excellent speaker, Dr. Anuj Maheshwari. He's a scholar, he's a researcher, he's a very good teacher, and he has published various presentations, and he's a very good orator as well. He's a recipient of the 2016 Nobel Achievement Award in Hypertension. He's a champion, a well-being champion by the American College of Physicians. So this session is very highlight because it is the last session of the day. I just want to know from the speaker whether all patients with type 2 and type 1 should be screened for sleeping disorders in routine practice. Over to you, Dr. Anuj, sir, for the session.
Thank you. Thank you, Dr. Mohan, for wonderful introduction. Thanks to my dear friend Jyoti, and congratulations to my dear friend Jyoti for organizing very nice seminar. In fact, in a very nice webinar, and very frequent interval, he is organizing wonderful programs, and I'm very happy that he is keeping me a part of that. And it's really very apt time to keep the insomnia and diabetes. When we are really going to sleep after this webinar, then it is fantastic to know about something insomnia. It's really a different kind of a topic at the end of the day, and I think you people will be happy to share all these information with me. Can you all see my screen now?
Yes, we can see the screen.
Yeah, that's great. So in next 15 minutes, we shall be talking about insomnia and diabetes. What is insomnia? Is it really a passive state, what we really believe? No, it's not at all a passive state. It's an active state that is critical for our physical, mental, and emotional well-being. Defects in sleep quality and quantity can result in metabolic errors and cardiovascular dysfunction. This is well-known fact. Most of the time, it is highly ignored in our life nowadays. In ancient times, sleep was very much respected and honored. But now we are sacrificing our sleep for every small thing, not only for the late night parties, but also for our work, our many successful grandeurs and many things which are yet to come may not be so much important, but first thing what we sacrifice, that is our sleep. The modern lifestyle has generated many diseases, of which type 2 diabetes, cardiovascular disorder, multiple kind of the heart diseases, and sleep disorders occupy the prime position. But all three are closely related with each other. Parallel to this is the rising prevalence of the type 2 diabetes in our country as well as across the world. Now let's have a few words about how does this insomnia impact glucose metabolism. Sleep is a metabolic regulator. Sleep debt has its own harmful effects on carbohydrate metabolism. There has been a study by Van Helder who has shown that insulin response to an oral glucose challenge has been more when it has been tested in the patients or in the people, those who were kept awake for last 60 hours. So once the people were awake on the last 60 hours, when they have been given the oral glucose challenge, they required more insulin to meet that challenge. This suggests that an insulin resistant state is induced by acute sleep deprivation. Chronically reduced sleep times are associated with obesity. The same reason, sleep deprived subjects have daytime sleepiness and have a tendency to overeat and eat fast. And of course, there are some other things which really take away our sleeps, like chewing tobacco, smoking. All these are the factors which are not only take away our sleep, but also give rise to type 2 diabetes. Subjects which are deprived of the sleep for several days or more become irritable, fatigued, unable to concentrate, and many of the time disoriented. Considerable stress is generated. Stress hormone like ACTH and cortisol are secreted in the high amount. Usually they are also high in the early morning and low in the late evening. But once these kinds of the stresses are there, they are high. Other than these timings also. These effects results from a 24-hour cyclic alterations in the signals from the hypothalamus that cause cortisol secretion. It has been demonstrated that glucose tolerance is markedly better in the morning than in the evening. Chronic sleep restrictions has been coupled with eating contributes separately to the development of the weight gain and ultimately leading to the obesity. And we have seen in many offices, many workplaces, a nap pod. Actually, these nap pods are used by those people who keep themselves awake across the night, and in the daytime they feel sleepy. And it is said they take a power nap to boost their performance. Actually, they try to regain their energy, what they have lost across the night. So chronic sleep deprivation in young healthy volunteers has been reported to increase level of the pro-inflammatory cytokines, decrease parasympathetic, but increases the sympathetic overdrive, increases blood pressure, increases cortisol level, as well as increase insulin level together with the blood glucose level. So hyperinsulinemia with hyperglycemia remains there. Shift working is again a very important risk factors for all kinds of the metabolic diseases, but of course very much for the diabetes. How does it cause it? Shift work means working in odd times in night results in the disruption of the circadian rhythm. It can have deleterious effects on the metabolic equilibrium and which can precipitate diabetes. There has been data from the Sleep Heart Health study which indicate that people sleeping 6 hours or less and those sleeping 9 hours or more per night have a higher prevalence of the type 2 diabetes and impaired glucose intolerance. This is in comparison to the people sleeping 7 to 8 hours per night even after those with insomnia symptoms are excluded, suggesting that voluntary sleep restriction may account for some of the public health burden associated with type 2 diabetes. So in nutshell, very long hours of the sleeping as well as small hours of the sleeping, both are causing type 2 diabetes and impaired glucose intolerance. Both are increasing our insulin resistance. Let's have few words about the obstructive sleep apnea. Obstructive sleep apnea is very important reason of insomnia apart from other causes of the sleep deprivation like restless leg syndrome, many of the time excessive sleepiness. They all lead to the metabolic disorders, but obstructive sleep apnea has got the strongest association with all these metabolic disorders. In clinical practice, detailed sleep history is mostly not recorded. But detection and treatment of the sleep disorders in diabetes is essential because their treatment is highly rewarding. Because if you can really take away these sleep disorders, you can stop the people becoming type 2 diabetic. Let's have few words about the sleep disordered breathing. This sleep disordered breathing is mostly caused by the airway narrowing. Sometimes people present with the snoring, upper airway resistance syndrome, and of course with sleep apnea. What exactly happens? You can see in this picture that sleep apnea, airway has got narrowed, low oxygen is being supplied, and once the oxygen level is low, automatically the heart shall be stressed. So this is the reason for which the patient ends up with the cardiovascular adverse outcomes while having the obstructive sleep apnea. It must be appreciated that obstructive sleep apnea is the risk factor for the development of hypertension, ischemic heart disease, diabetes, and stroke. Habitual snoring predicts the onset of the diabetes. So that's why habitual snoring must be taken in consideration if it happens, and it can really help you in stopping the diabetes. There has been another study in which Gislason reported that diabetes was associated with near frequent complaints of difficulty in initiating sleep in 21.1% people. Difficulty in maintaining sleep, 21.9% of the people, and excessive daytime sleepiness could be noticed in 12.2% people. The sleep complaints are often related to the presence of underlying disorders of the breathing, nocturia, physical complications of the disease, and underlying depression. Polysomnography done in diabetic subjects revealed more wakefulness, a high number of the awakening, and fragmented sleep. So this sleep apnea has been found to be associated with high plasma insulin level at the fasting stage, together with high glucose level. So this is the combination of the hyperinsulinemia with hyperglycemia. Of course, this is a combination which is usually seen in the obesity. So that's why the sleep apnea has been demonstrated a higher degree of visceral but not subcutaneous fat compared to their obese control. As we all know that obstructive sleep apnea can be defined as a repetitive pharyngeal collapse in sleep resulting in cyclical hypoxemia, cyclical hypertension, and release of stress hormones as well as catecholamines. The other nocturnal symptoms, which include apnea, choking, dyspnea, restlessness, diaphoresis, excessive sweating, sit reflex, drooling, somniloquy, frequent changes of the posture in the sleep, unable to sleep supine, and bruxism. In diabetic subjects, there is often postprandial drowsiness, poor concentration, fatigue, and depression is usually seen. Therefore, symptoms can be quite confusing and misleading. Many of the time, patient ends up at the psychiatrist instead of reaching to the diabetologist or the endocrinologist. So let's have a flow chart showing the close association of sleep deprivation and obstructive sleep apnea as well as which is leading to the type 2 diabetes. What we have seen in last our few slides, what we could establish that sleep disordered breathing together with obstructive sleep apnea with apnea activity leads to the cyclical hypoxia, increased sympathetic activity, or we can say the sympathetic overdrive takes place, leading to the high level of the catecholamine secretion, cortisol secretion, which ends up with metabolic errors causing insulin resistance, ends up into the type 2 diabetes, and which is also caused by the altered insulin action and altered glucose disposal, which takes place in this type 2 diabetes. So all these factors are leading to development of the type 2 diabetes in our patient, those who are having insomnia or sleep deprivation. We all know that sympathetic stimulation and decreased insulin sensitivity is occurring together. Sympathetic stimulation or sympathetic overdrive causes the high insulin resistance. It results in the release of the stress hormone, catecholamine. Both these effects are known to decrease the insulin sensitivity and worsening the glucose tolerance. There has been seen the strong possibility that sympathetic nervous system activity, corticotropic function, and systemic inflammation are associated with subjects with short sleep duration and insomnia, thereby causing the metabolic dysfunction. Patients who are sleep deprived often exhibit fast eating and binge eating, which adversely affects glycemic status, digestion, of course, increase in weight gain. So what we could understood here that
Sir, we
obstructive,
have 2 minutes left.
high level of the cortisol, high REM sleep deprivation, and leading to the type 2 diabetes mellitus. Nocturnal excessive cortisol and catecholamine secretion can also spill over in the day. Spillover effects results into the fasting hyperglycemia. Hypothyroidism can be associated with OSA. Daytime tiredness, sleepiness can be confused with hypothyroidism, and many of the times it has been seen that administration of the thyroxine without treating OSA can precipitate cardiovascular events in sleep due to cyclical hypoxemia, particularly in REM sleep. So potential mechanism which links this sleep apnea to the glucose intolerance are through the sympathetic activation, through the HPA axis alteration, which increases the level of the cortisol, oxidative stress, activation of the inflammatory pathways, through which inflammatory markers are raised in the blood, and changes in the adipokine profile by raised level of the leptin and reduced level of the adiponectin. All these things ends up with the high insulin resistance, low pancreatic beta cell activity. So ultimately it goes into the beta cell dysfunction, causing the type 2 diabetes or glucose intolerance. There has been a study which has checked the sleep duration and risk of type 2 diabetes. So sleep duration is also found to be having a U-shaped effect with the occurrence of the type 2 diabetes. A U-shaped dose response relationship has been observed between sleep duration and risk of developing diabetes, with the lowest risk observed at a sleep duration category of the 7 to 8 hours every day. So compared with 7 hours sleep duration per day, the pooled relative risk for type 2 diabetes were 1.09 for each 1 hour shorter sleep duration among individuals who slept. So both short and long sleep durations are associated with a significantly increased risk of the type 2 diabetes, underscoring the importance of appropriate sleep duration in the delay of prevention of type 2 diabetes. There is a close relation between sleep, circadian rhythm, obesity, insulin resistance, hypertension, and cardiovascular disorder, which needs to be dissected and managed. There is evidence to show sleep disorders like obstructive sleep apnea, insomnia, short or long-term sleep duration, restless leg syndrome are potential risk factors for insulin resistance, glucose intolerance, type 2 diabetes, and metabolic syndrome. Thank you for your kind listening. I think the question which has been asked by the chairperson in the beginning of the talk, that whether, so I would like to say that type 1 diabetes is mostly having the disorders of the apnea and mostly having the disorders of the sleep deprivation, while the sleep deprivation will lead to the type 2 diabetes. Yes.
You can stop sharing, Anuj.
Yes.
Yeah, thank you.
Anuj, fantastic talk.
Thank you. Thank you. Thank you, Bansi.
So I will be share some questions. And I would like to congratulate Dr. Anand Masses for a very excellent speeches. And we have got one or two questions we asked in the audience. One is, do you have any data on that? There was a question shared by some audience.
Yes.
And this is the temporal effects, and what is the nature of this? And that was a question asked by.
Thank you. There is in India, I don't think there is any exact known prevalence of type 3 diabetes in our country, but the association has been well studied and it's recognized as a well-known entity now, the association between Alzheimer's disease and diabetes, but the exact prevalence we do not know. The cause of the effect again is a big question. Aging itself is a risk factor for Alzheimer's disease, and diabetes is a disease of aging, and microvascular complications in the brain may be one part responsible. And one thing which has rightly been recognized is insulin resistance at the level of the brain. That is why they have shown that some drugs like DPP-4 inhibitors and thiazolidins used in people with Alzheimer's disease can prevent the progression of the disease and improve cognitive extent to some extent.
Another aspect of probably that person who has been asked the question is whether due to the recurrent hypoglycemia and other complication of diabetes that leading to the dementia and
yes, I think loss of cognitive dysfunction is well known. I think even in my presentation I said repeated subclinical hypoglycemia episodes can lead to dementia and loss of cognitive dysfunction in elderly. That's why we are worried so much about hypoglycemia in the elderly more than in the young.
I have got one more question to you, sir.
Yes.
Now, the ADA, ESADA, and all giving a guideline what the drugs to be started in general diabetic population.
Yes.
So look into the pathophysiology of diabetes and the progressive beta failure and non-response to the sulfonylurea and the duration of the diabetes too much, the metformin in elderly may be an issue. So do you want to have a separate first line drug to be started, a guideline for the elderly people like a gliptin or SGLT rather than talking that I also started with
yes, I think more than that we should recognize which are the drugs we should try to avoid in the elderly. Particularly, I think first on the list would be sulfonylureas, second would be thiazolidone. These two drugs have to be very carefully judiciously used or even avoided in the elderly. DPP-4 would be the drug of choice. First drug of choice would be metformin and DPP-4 in elderly.
So we can avoid it and start and separate the guideline for the elderly to start with the OHA if it is required. Rather than the
metformin can be used as long as the renal functions are good. Metformin could be used in the elderly. DPP-4, particularly vildagliptin, has got a lot of evidence-based use in elderly. We could use any of the DPP-4 inhibitors because our aim is to prevent hypoglycemia and avoid the side effects of the drugs like thiazolidones and hypoglycemia due to sulfonylureas. Jyothidev, you want to add anything?
No, it's fine. It's fine. It is perfect. It is perfect. Dr. Mohan.
Yes, sir. Yes, sir. Excellent talk by Dr. Anuj. Sir, one question in the question box is the duration of sleep? It is 6 to 8 hours, or is it the correct schedule that is matters the most in diabetes?
Both the things matters the most.
Combination
of course, the duration must be there. It is proven by the data. It is proven with the evidence that less than 6 hours sleep is detrimental for diabetics as well as for the non-diabetic. Even those who are non-diabetics are prone to get the diabetes. They can develop diabetes earlier if they are having the sleep deprivation. At the same time, if they are the people sleeping more than 9 hours, they have also been found to be on the higher risk of getting diabetes. But at the same time, the studies are going on as well as there has been some evidence if the schedule of sleep is not so proper. Suppose if in the evening times we are taking the sleep, then probably the secretion cycle of the secretion of ACTH and cortisol shall be disturbed. What we have seen that ACTH and cortisol is maximally secreted in the morning. At that time, if we can eat more because of what? But what do we do really? We actually eat more in the evening when our ACTH and cortisol is very less. So therefore, we eat always at the time where the insulin is comparatively not available, or it is available in the way that it cannot be digested or it cannot be metabolized properly, because of what we develop the weight gain in evening time eating. So that's why this evening time eating is actually the time of the insulin resistance time, and because of what this insulin resistance, we develop the weight gain in the evening eating, more of the evening eating. So that's why the same.
That's a point, because yeah, what I have observed is that PCOD also we have diabetes. So in puberty period where there is a hypothalamic drive, so that is what I feel that in that period the sleep issues are also common.
Yes.
So hormonal effect in the puberty period, if the child is having a more of screen time and less of sleep, the quality of sleep is the one which holds the most. Because if you have a correct schedule, if you know your sleep pattern and you adapt it towards adulthood, that is the best for that person. So it is individual choice whether it is a sleep quality or sleep duration, but exactly what is required is the sleep. What is the quality is important. Should have a good quality of sleep.
Yes, I agree with you.
And it's difficult to screen in a general practice. What I feel, we cannot screen everybody for the sleep, but whenever you have a profession which is occupation hazard for sleep, that is a pilot who is traveling more. Nowadays we don't travel, but those who travel more, those who have a night shifts more, those people we should screen more. was diabetes.
Very rarely people come to physician for the sleep deprivation.
Correct.
Most of the time, either they start taking the sleeping pills by themselves, or they go for the psychiatrist or some psychotherapist to take the help. Very rarely they think that physician, or they rarely think that diabetes or type 2 diabetes may occur because of the continuous sleep deprivation, or their obesity may be related to the continuously sleep deprivation. Very rarely and very few people understand this.
One last question from Dr. G. Prakash from Salem. He's asking, is there an association of insomnia and glycemic control?
Yes, that's why we are talking.
Is it completely proven or not? But we have definitely thinking about it. It is not
completely proven that when there is a deprivation of the sleep, then stress hormones are more. And of course, it will lead to the hyperglycemia. So whenever there will be the stress hormone, ACTH level or cortisol level will be high, hyperglycemia shall automatically take place at that time.
Okay, thank you, sir. I think over to the organizers. Thank you for involving me. Thank you very much. Good night. Good evening.
Thank you very much. Thank you all.
Thank you, Jyothidev.
Jyoti,
you're not inviting us for dinner. There is one thing in your hospitality we are missing today.
Yeah, absolutely. We are missing the beach, we are missing the hotel, we are missing the networking.
Yes. We'll catch up next year.
Yeah. Very soon.
Thank you. Good night, all of you.
Yeah, good night. Thank you so much for being with us.
Thank you.
Thank you, sir. Namaste.
Thank you, Chairperson, sir.
Thank you. Good night.
Anyways, bye.
Bye.
Thank you, everyone. That was a beautiful day today, and all the sessions were very beautiful. And I would like to thank everyone for participating, and a special thanks to our speakers and chairs. So tomorrow we will be starting our sessions at 11 a.m. at both the halls, at winter and summer hall. Good night.